language paradigms includes verb generation, silent word generation, semantic decision, sentence completion, syntax, word pair, motor activity, and reporting. Now, these the first 5, 6 one are called the language paradigms because they are used to elicit the language areas of brain. Language areas of brain include the Broca's area, the Phoenix area, the Broadman's area, some elaborate areas are there. So these areas are responsible for the always called the cognitive areas of brain. See, if you want to judge something, then we need the help of that particular area. If you want to discriminate between the good and bad, then also we need the help of that particular language area. So we use these paradigms to elicit the language areas of brain. In verb generation, what we do, we usually show the pictures of some noun forms like cat, pen, book, and the patient or subject have to think about the verbal function of that particular picture. For example, if you show book, that means the patient have to think, yeah, the book is meant for reading. If you show the picture of a mobile phone, then you should think that it's meant for reading. A pen is meant for writing. A mobile phone is meant for calling. Like that, you have to think. You should not supposed to move or talk in the MR room, in the MR gallery. You should only think about the verbal function. Then silent word generation, we'll give alphabets like A, B, C or something like that. And the patient have to think, develop or generate as much of words as he can. Like A for apple, and like that. B for ball, boy, like that. He or she have to generate as much of words as he can during the task period. Then semantic decision, to judge the meaning of a sentence. We will display a sentence like the sun rises in the north. So here we judge the sun rises in the north, whether it is true or false. Then syntax, grammatically accepted language. We will change the grammar. For example, there are 50 persons in the room. So we will give the display as persons 50, room in the. So again, the patient will judge whether that sentence is grammatically correct or not. It can be in your regional language as well as English. We will display the sentences. Then word pair. We will give related words and non-related words like table and chair or table and stone. Again, we have to think whether it is related or non-related. So the idea is that his language area has to be elicited. So how it is being elicited? So violet rust, it will be paramagnetic will be there, and violet activation, paramagnetic. So then motor activity like movement of right hand, movement of left hand. So it depends on where the lesion or pathology is there, pathology exists. Suppose the pathology is in the supplementary motor area, then we will do the motor fMRI scan. Suppose it is in the language area, then we will do the language fMRI scan. And lip outing, movement of lips to and fro during the activation pattern. So these are all some of the paradigms. And most of the time, the dominant hemisphere, see mostly for 95% of individuals who are right-handed individuals will be having the left side of the brain as the dominant hemisphere. So the determination of the dominant hemisphere is also important, whether the patient is having a right side dominant area or a left side dominant area. So that whole thing is also important. So if a patient have a right side lesion in the language area or in the, as you say, abdomen or in thalamus, again the surgeons will be in the complication because the removal of full tumor or the complete tumor may cause a vegetative state for the patient in his future life. So he needs to, he will send the patient to a fMRI room, MRI room for detecting the language areas or detecting the cognitive areas of brain. Then coming about the language areas of brain, we have mostly the Wernicke's area, and the Broca's area. See, I am speaking from here. That means my Broca's area is now activated. That's why I am speaking. You people are listening to me. Means your Wernicke's area is now being activated. Suppose you want to ask me a question, you will rise up and will ask me a question. So that means that time your Broca's areas are activated. So Wernicke's area is always involved in the understanding of written and spoken language. You are reading a letter or you are reading something. That means your Wernicke's area is being activated at that time. You can see in hospitals the patients may have difficulty in obeying the commands of sisters or doctors. Why is it so? Because the patient with Wernicke's area will be difficult to understand or comprehend what the doctors or nurse is telling to him. And Broca's area is involved in the production of speech and language. A patient with Broca's aphasia will be difficult to convey the language or convey the message to the usage audience. He may have many difficulties in conveying his ideas or feelings. So mainly the fMRI, the language paradigm can be divided into three as expressive paradigms, which are used to elicit the language productive areas, that is broadcast, and receptive paradigms, which is used to detect the comprehension of language or otherwise to elicit the Wernicke's area. And we have one more paradigm called semantic paradigms to detect which hemisphere of the patient is dominant, whether the left hemisphere or the right hemisphere. So that's all about paradigms. See, when I used to present this fMRI, I used to talk one incident happened to my hospital, which happened to me. It happened in our hospital some years back. A Tamil patient from Tamil Nadu. Actually, her mother tongue is Tamil. And after the epilepsy surgery, she couldn't speak in Tamil. She forgot to speak her mother tongue. But what she can comprehend the Tamil. When sister or nurse speaks, she can understand the Tamil language, but she couldn't speak in Tamil language. She could convey the message in English, but she's not able to present her ideas or to give the feedback in Tamil. This is because she has generated, her language area has been affected because of the epilepsy surgery. This Broca's area, the area to express, or the area where the expressive area has been affected because of the surgery. While she speaks English, because she has developed a separate language area for English, because she acquired her language area, she has acquired the language area for English in the later part of her life, maybe in her teenage. So that is why she has no problem expressing in English, but she forgot or she couldn't speak in Tamil language. So some case presentations. This is a 13-year-old girl who came to our department for an epilepsy surgery. So you can see a focal cortical dysplasia, which is the reason for the epilepsy, seen in the left hemisphere of brain. So I told that most of the right-handed individual will be having a left dominant hemisphere. So this child actually was a right-handed child. So the doctor is clear that as she is a right-handed person, a right-handed child, her left dominant hemisphere may be affected due to surgery, because of surgery, and they sent for the fMRI. And we done blood generation and silent blood generation, and found out that activation is seen, Broca's activation is seen on the right hemisphere, and we done this word pair and semantics for the Wernicke's area, and also seen that activation is seen in the right hemisphere itself. That means the surgeon can confidently put his knife to remove this FCD from brain. This is another example for a patient having a big tumor in the supplementary motor area, and we've done the right leg motor, and you can see the lesion is far away from the activation side. That means the patient will be safe even after the removal of the tumor. Means the supplementary area may not be affected because of this surgery. This is another example. You can see the activation is seen very close to the tumor, means the doctor or the surgeon have to be very cautious while removing this tumor, otherwise the ability of a movement of the right hand may be affected. So this is an example of doing an fMRI for an autistic patient. So actually, this patient is inside the MR room, and the technologist is giving IT instructions to the patient. So he is asked to write the names of his father, his mother, or some relatives during the activation time, and during the rest time, he will be instructed to be in the rest. He should not do anything and remain calm. So this is how it's being instructed, and the sound is not there. So it's being given instruction. Okay. So this is he is doing his during the task pattern he is writing the names or some whatever it may be, maybe the names of his relatives, maybe some other thing we may ask to do so. So that thing going on. And of course, the clinical application of fMRI includes the localization of brain function, then the localization of language function, the surgical treatment of epilepsy, then the localization of development cortex before surgery, and for brain plasticity, which is also used as a marker for pathological state for identifying the brain clinical expression of the Alzheimer's disease. And the limitations include patients with Parkinson's, or because the patient may have severe tremor inside the MRO, it may be difficult for them to comprehend the things what we are giving, what information we are giving. And mentally retarded patients also not covered for fMRI, and stop patients because they may not be able to accept the command given from the console. And sometimes Alzheimer's patients also find difficulty remembering the task where we give the instructions. And of course, obesity patients also, because for fMRI sometimes the patient will lie for half an hour or 45 minutes or so. So obesity patients may also find difficulty to remain calm inside the MRO for such a long time. So thank you very much for the attention.
Thank you, Manish. It was okay. You can announce the next chair.
Thank you, sir. Now I would like to invite our second speaker for this session, Mr. Aditya Nagraj, PGI Chandigarh, to the dais. He will be speaking on future trends in MRI safety, emerging technologies and protocols. I would like to request our chairpersons to please introduce him.
Mr. Aditya Nagraj, PGI Chandigarh. Now we speak about the MRI safety, emerging technology and protocols.
A very good afternoon to respected chairpersons, honorable dignitaries, and friends. Today's topic of my presentation is trends in MRI safety. Before beginning of my presentation, I would like to quote something. Without radiology technologists, it's all a guesswork. So we are the backbone of the medical healthcare. Beginning with the introduction, MRI is a medical diagnostic tool to help doctors to diagnose disease by scanning the insides of human body. It is a non-invasive and non-invasive imaging technique. In an MR examination, the patient is exposed to the following: strong magnetic field, RF waves, audible noise. What is a magnetic field? The magnetic field is an invisible force that can attract objects that have iron content. The stronger the magnetic field, the stronger will be the force of attraction. Objects that are not ferrous will not be attracted to the magnet, for example, wood, plastic, gold, silver, aluminium, brass, and copper. The magnetic field can be measured in terms of Tesla. Our Earth has a gravitational force of 0.00005 Tesla, and MR is 30,000 times stronger than the Earth's magnetic field. There are some general misconceptions about the magnetic field. If the system is switched off, then the magnetic field will also be off. It is a general misconception. This is a big object. The magnet is not strong enough to pull it. It is also a misconception. And if we think that this is a small object and it is not necessary to remove from patient or my pocket, it will also be a misconception. Some general knowledge about the magnetic field's effect. It is very strong. It can pull objects up to 100 of kilograms. 1 kg iron object will feel like almost 100 kg inside a 1.5 Tesla magnetic fields. Both the big objects and small sharp objects may cause injuries or even death to the people around or inside the magnet. Some important take-home points. The magnetic field of a superconductive magnet is permanently on and it cannot be switched off by the users under normal conditions. Safety rules. So we have 5 main categories: magnetic fringe fields, 5 Gauss limit and line, ECR safety zones, MR compatibility, and specific absorption rate. First of all, magnetic fringe fields. It is a peripheral magnetic field outside the magnet core. Depending on the design of the magnet in the room, a moderately large fringe field may be extended for several meters around, above and below an MR scanner. It can cause interference with electronic devices including pacemakers. So it is a diagram showing that how when the distance is increased from the magnetic core, the magnetic fringe field is decreased. So 5 Gauss line is considered to be the safe area. 5 Gauss limited line, it specifies the parameter around MR scanner within which the static magnetic fields are higher than 5 Gauss. The limit is 10 times higher than the average Earth magnetic field but lower than the magnetic field in electric trains such as subways, which is up to 7 Gauss. So the threshold for access to MRI areas, 1 Gauss is equal to 1 into 10 is minus 4 Tesla and 5 Gauss is equal to 0.0005 Tesla. This is an illustration of 5G line in an MRI scanner room. American College of Radiology Safety Zones. So they have defined 4 safety zones within MRI facilities. There are 4 zones, Zone 1, Zone 2, Zone 3, Zone 4. So as we can see in the flowchart, Zone 1 is a free area which is accessible to the general public without supervision. Zone 2 is still a public area, but the interface between unregulated and the strictly controlled one, 3rd and 4th. Zone 3 is an area near the magnet room where the fringe gradient or RF magnetic fields are sufficiently strong enough to present a physical hazard. And Zone 4 is synonymous with the MR room itself, console room itself. MRI compatibility. There are 2 things. One is MR compatibility and MR conditional. So MR compatibility, it is considered to be MR safe and the potential for the injury of individual. When the device is introduced or used in MRI environment, it does not pose an increased safety risk to the patient or other personnel. MR compatible. Now these are the screening guidelines. Absolute contraindications to MRI, relative contraindications to MRI, post-op period, contrast media, and NSF in pregnancy. The absolute contraindications include electronically, magnetically, and mechanically activated implants, ferromagnetic or electronically operated active devices like automatic cardioverter defibrillators. Absolute contraindications include cardiac pacemakers, metallic splinters in the eye, or ferromagnetic homeostatic clips in the central nervous system. Relative contraindications include cochlear implants and other pacemakers, insulin pumps and nerve stimulators, lead wires or similar wires. Post-op period. If the metallic object is a passive implant, that is, there is no electronically or magnetically activated component associated with the operation of the device, and it is made from non-ferromagnetic material, the patient may undergo an MR procedure immediately after implementation. For an implant that exhibits weakly magnetic qualities, it may be necessary to wait a period of 6 weeks after implantation before performing an MR procedure. However, patients with implants that are weakly magnetic but rigidly fixed in the body may be studied immediately after implantation. Contrast media and nephrogenic systemic fibrosis. So it has been observed in patients with severe kidney disease or dysfunction receiving gadolinium-based contrast agents. They are characterized by extensive thickening and hardening of the skin with fibrotic nodules and cracks. The disease is progressive and can be associated with a fetal outcome with no definitive cure. Other approved agents, some of them are Abliver, Eovist, Multi-Hands, Prohance, should be used in patients at risk of NSF only if the diagnostic information is essential and not available with non-contrast enhanced MRI or other imaging modalities. Post-MRI advice for several days hemodialysis with increased rate and volume to enhance elimination of gadolinium-based contrast agents. In pregnancy, the Safety Committee of Society for Magnetic Resonance Imaging in 1991 states that MRI may be used in pregnant women if other non-ionizing form of diagnostic imaging are inadequate or if the examination provides important information that would otherwise require exposure to ionizing radiations. So there is a risk versus benefit ratio in every MR procedures to be done in the case of pregnancy. Relatively few studies performed in pregnant human subjects exposed to MRI or MR environment. There are no published reports on persons exposed to magnetic fields, including staff at MRI departments. They have a higher incidence of genetic damage to their children than found in the average population. Hazards, risks, and side effects. So these are the points: magnetic forces, magnetic shielding, acoustic noise, claustrophobia, quenching, contrast media, absorbed dose, cardiac risk, magneto-hydrodynamic effects, and nerve conductivity. The magnetic forces include the missile effect, which is a very dramatic and dangerous phenomena. It occurs when a metal object is pulled into the magnet with a great force. It It can be lethal danger if one is hit by an understrained object in flight. So this is a news which was a 6-year-old, when a 6-year-old boy was killed in freeing MRI accident, undergoing an MRI examination at a New York area hospital. It is considered to be the first fatal MRI accident in the world. These are some images showing the MRI accidents when the metallic objects which are not supervised or which which was not stopped from entering the MRI console room get pulled by the MRI magnet. Acoustic noise. It is a field created by pulses of the current through, caused by the interaction of the magnetic field created by pulses of the current through the gradient coil with the mean magnetic field. The loudest noise range between 110 to 120 decibels. As the field is as the magnetic strength is increased, the acoustic noise is increased. It may create discomfort, anxiety, and even temporary hearing loss. So to avoid this, we prefer the patient to wear disposable earplugs during the MRI scan. Claustrophobia, it is a physiological reaction to being confined in a relatively small area. It reported in about 1 to 4% of cases as a reason to interrupt the MRI examination. Quenching. Quenching the magnet is deactivating the magnetic field of the magnet. A quench is an escalating reaction to heat. It causes the cryogen, which is the helium itself, to boil off rapidly, which in turn causes the loss of the static magnetic field. It may occur unexpectedly or from pressing the emergency button. As a superconductive magnet becomes resistive, heat will be released, and to protect patients and operators, the evaporated helium requires emergency venting system, quench pipe through the roof or the wall. So this is the image showing the helium quenching throughout the building. Contrast media. Gadolinium-based contrast agents are extremely well tolerated by the vast majority of patients. Reactions resembling an allergic response are very unusual and vary in frequency from 0.004 to 0.7%. The frequency of acute adverse reaction is about 8 times higher in patients with a previous reaction to gadolinium-based contrast media. Persons with asthma and various other allergies to food or medications are at greater risk, with reports of adverse reaction rates as high as 3.7%. Contrast media, in case of breastfeeding mothers, expected systemic dose absorbed by the infant from the breast milk is less than 0.004%. The available data suggests that it is safe for the mother and infant to continue breastfeeding after receiving such an agent. If the mother remains concerned about any potential effects to the infant, she may abstain from breastfeeding from the time of contrast administration for a period of 12 to 24 hours. Current radiology practices and recommendations discourage the use of gadolinium-based contrast agents during pregnancy because their safety for the fetus has not been proven. Because it is unclear how they will affect the fetus, these agents should be administered only with caution. Safety guidelines. The general safety information includes that we should ensure the system is operated by qualified personnel only, provide safety training for medical and non-medical staff, warning signs must be clear in MRI area for the patients as well as staff, and any accident should be reported to the proper authorities immediately. The door of the MRI room should be closed at all times. It must be a restricted zone. Create emergency plan for evacuation and call service to notify incidents of emergency. And we should not use unapproved accessories or softwares. So these are some of the signs we can find in an MRI room, MRI area. This is the diagram showing 4 safety zones of MRI. Safety information for medical staff. We should observe warning signs. Do not enter MRI room unless authorized by person or duty, and all equipment must be checked for MRI compatibility. Safety guidelines. Patients must be screened. Personnel must be screened if they are not familiar with the MRI environment before, and patients' data should be recorded. Emergency plans should be devised and discussed with emergency staff. Emergency phone numbers must be available and displayed on the MRI area. In the event of an emergency or accident, the patient should be removed from MRI room and notify emergency staff. Do not press quench button if no one is stuck inside the magnet, as there is no immediate danger to the patient or staff. ERD or quench button can only be pressed in two conditions: when it is life-threatening to the patient or staff struck by magnetic objects inside magnet and cannot be removed. Safety personnel such as a fireman needs to put out a fire in the MRI room. Do not press the quench button if an object is stuck but not life-threatening, and inform the hospital authorities for next course of action. Other emergency buttons that can be activated anytime if required are electrical stop button, patient table stop button to remove patient from magnet by pulling the table manually. To conclude, I would like to conclude my presentation by mentioning two factors which is very necessary for any healthcare worker. One is karma. So as a medical technologist, our karma is to produce best possible diagnostic images. And one is dharma. So our dharma is to ensure patient care and best patient safety protocols. Another factors, these two factors can be accomplished by following 6 major factors, which is also the motto of our ISRT: commitment, leadership, integrity, professionalism, compassion and creativity. Thank you.
Thank you for the good sessions. MRI safety as well as functional MRI. Is there any question from the audience side? Or to move which based on the first session as first talk? MRI safety. Please give mic to the doctor.
Any other questions?
No.
The difference between MRI compatible and MRI conditional.
MR compatible and MR conditional are two different phenomena. MR compatible is considered to be the safest option, completely safe for a patient to undergo MR scan. MR compatible is considered to be the safe option when a patient, we say that the patient is MRI compatible, or if he has any implant, then it is. If it is MRI compatible, then it is totally safe to conduct an MRI scan. But MRI conditional equipment, it is that equipment that is known to have no hazards under specific MRI environment. For example, we can use specific magnetic strength, so up to 1.5 Tesla or something like that. So currently Siemens has introduced MR conditional drug trolley, which is safe up to 7 Tesla. So we can say it is MR compatible.
What हमारे technologists will do? What हमारे technologists will do during MRI of a sick patient?
Sick patient means everyone is sick.
Yes, sir.
In case of emergency or in case of
Case of
Your
emergency.
question, this specific question that all patients who are coming to
What is
they are
your
sick.
question?
What kind of
What?
sickness you are?
Patient is sick. We could not do the MRI or can we go for the MRI? Your question is like that.
Yes, sir.
okay, sir. So if the patient is all the patients who are coming to hospital are considered to be sick. But if we have an emergency situation like the patient is admitted in ICU or some life-threatening or some critical wards, and if the suppose we are suspected of stroke, then it is an MRI has to be done or MRI is referred by the consultant, then what we can do, we have to act like a team because stroke time is the major concern. So what we do, everyone, we have to make sure the MRI technologist should make the patient, the trolleys who are coming, on which the patient is coming, and nursing staff, they might be untrained in MRI room. So we have to make sure that any MRI dangerous object should not enter the MRI room. Such as we have oximeter, pulse oximeters. If they are not MRI compatible, they should not be allowed. So in such situation, MRI is not usually first choice of imaging. Usually in such cases, not any other the fast acquisition or fast imaging system, fast imaging modality is used. But if the MRI has to be done, then we have to act like a team and ensure that the patient is compatible to do MRI scan.
Sir, I will refill for the question. What he is meant to say is a different way. Because the patient is sick, how are you going to screen the patient? Because we don't have any history of behind that. The patient attender also is a new to them. Sometimes what happens, the patient will come with a, you will catch the attender somewhere, those unknown persons. Because without the attender, we have to do the MRI. So that you will catch out some other person, they request an attender for that one, request say that. How do you going to screen the patient? Patient would not be able to see that is sick in bed. What are the precautions going to be for screening purpose? This time we refill the questions.
So I think the screening is must. If the patient has some implant, we have to take the history from the resident itself, from the company resident. And I think if it is not safe, if he has some implant, or if he has the doctor knows nothing about the history.
In case the patient has some mental or fever or something like that, the patient comes.
I don't think so. MRI should be MRI should be done.
You will going to reject the patient and you do the scan.
So it all depends on the radiologist.
No, sir. Still, the MR technology take the care of the things you got allowed to do the MRI unless we confirm with the things. Either you can go for the CT.
The information should be done, sir. Otherwise, other options are available.
Is there any questions on fMRI?
One more question, the last question, simple one. Recently, the MRI magnet room door has been modified, safety purpose. Recently, I think for the 6 months before they modified the room door entrance. Any idea about that?
No idea.
Previously, the door entrance will be open inside.
Yes.
So now they made it outside open. The safety purpose. In case of leakage of gas and all, the door get locked.
So in my institute, the door always
Development has
open.
been made in the MRI safety. They made the door opening outside.
In my institute, the door is open outside only.
Yes.
Is there any questions on fMRI? Okay, thank you.
Thank you. Now I would request our chairpersons to please come forward, and I would request the speakers of this session, Mr. Mahesh and Mr. Aditya Nagra, to please come forward on the stage. I would request Mr. Rajiv Krishnan to please felicitate Mr. Mahesh. A huge round of applause for him. Now I would request Mr. Yogananda. Now I would request Mr. Yogananda to please felicitate Mr. Aditya Nagra. I would thank the chairpersons for chairing this session. Now it is time for felicitation of the chairpersons. I would request Mr. Judson, Executive Member ISRT, and Mr. Rajesh KM, Executive Member ISRT, to please come to stage and felicitate our chairpersons for this session. would request Mr. Jackson to please present the memento and the certificate to Mr. Rajiv Krishnan. And I would request Mr. Rajesh KM to please present the memento and the certificate to Mr. Yogananda. Thank you. Thank you, sir. Heading towards next session. Nuclear medicine is an essential part of medicine and will continue to grow in future. Along with its advancements, its important principles of radiation protection should also be firmly emphasized in daily practice. The introduction of VRL can probably help the optimization of radiation protection in nuclear medicine. The goal of radiation protection in nuclear medicine is to ensure that the expected medical outcome for the patient is achieved and the procedure is optimized while limiting the radiation risk to the patient and the medical public and medical personnel and the public. Eventually, the best practice and the safest practice should be brought to the clinical reality. On this note, I would begin our next session on nuclear medicine and radiation protection. I would request our chairpersons for this session to please come to stage. I would request Ms. Suruchi Jain ma'am, HOD Nuclear Medicine Department, AIIMS Bhopal, to please come to stage. A huge round of applause for ma'am, please. And I would request Professor Dr. Rajesh Parishcha sir to please come to stage. Now I would invite our speakers for this session to the dais. I would request our first speaker for this session, Mr. Dhananjay Kumar Singh from Yashoda Hospital and Research Center Ghaziabad, to please come to stage. And I would request our honorable chairpersons to please introduce him. He will be speaking on the topic radioactive waste management. A huge round of applause for him.
इसको माइक की जरूरत है।
Dr. Dhananjay Kumar Singh is from Yashoda Hospital and Research Center Ghaziabad. He will be speaking on radioactive waste management.
Thank you, Chairperson, for inviting me, and I would like to thank the organizing committee for giving me this opportunity to talk on radioactive waste disposal. So, this is the entirely different topic, the way we are moving in this conference. But this is a very important topic regarding the concern of practice of nuclear medicine. The way we enjoyed yesterday night, all must be agree that we must have produced lot of waste yesterday. So same way in nuclear medicine practice, we are doing the unshielded radioisotope in practice. So in our practice, it is bound to be happen to produce a significant amount of radioactive waste material. So in this my talk, I am going to discuss something about what is the radioactive waste and why it is a concern for radiation safety and why it is required to put under the management in systematic disposal. And there is some guideline, not only in India, this is under the regulatory framework. So, and how to be waste collected, segregated, and stored, and then if not possible, then we'll go for further treatment and ultimate disposal. We'll show also some examples to have some little bit idea about how it should be done. So this is we used to call in Delhi Ghazipur mountain. So see, it's like a hill, but in reality, this is the landfill waste disposal site, and such a way we have managed our government agency mismanaged that it created a mountain. After the active interference of Supreme Court of India, this mountain size is day by day is reduced, and current government hopefully it will sort out this concern of waste disposal, because now current Delhi government is active so smoothly that its height is going to be reduced day by day. So same way, we in most of in our nuclear medicine sector, in storage, radioactive waste storage, we are also almost similar way. Most of places, we are doing similar kind of practice, storage of radioactive waste, because of least awareness about the, if we will not store properly, then what will be going to happen? Like we can see, this is the cause of ignorance. We all know the Mayapuri incidents that was happened in 2010, and this incident was happened because of gamma cell irradiator. It was at that time 40 years old, and it was kept in just in Delhi University Physics Department, and Delhi University Physics Department RSO was retired 20 years back, and then suddenly everybody realized, what is this waste? We can throw out from the department, it's keeping unnecessary space occupying, we'll have some new lab there. So the department sold scrap as a scrap material, and it was taken by the scrap dealer from the Mayapuri, and then during a scrap, this pin, cobalt-60 pin, was got exposed, because till that time, when it was put as a scrap in Delhi University, it looked like a simple, just a heavy iron material that is not for use. But once exposed, then we all must be aware that it causes 6-7 people to die within a week span of time. So then, until that time, I'm telling you this fact, ARB was also sleeping at that time in India. Then ARB initiated itself, came in picture. Okay. Then survey all the areas, and lot of panic was created in Delhi. Casualty also, major, there is huge losses of business of a scrap dealer, because that area is completely evacuated. So I am telling this story to realize that if you not do the proper radioactive waste disposable, something will happen, and that may cause the life and economic losses too. See, the same type of incidents that happened in 2011 because of natural calamity, and Fukushima reactor, the accident on reactor number 4 and 5 happened, and because of this, there was a life and huge losses, huge panic in whole world because of scientists were telling that big area of Asia Pacific will going to contaminated seawater. So because of international pressure and neighboring country pressure, 100,000 of liter water was forced to store by Japan government, and that cost was more than 80,000 crore rupees. It's close to 1 trillion. And that tank life was going to end this year, 2023, if the government was not settled that matter. As per scientists' internal documentation report, it was communicated in media that still this water was not safe for release, but this is under wrap. Finally, IAEA decided that this water can be released in sea, and there is also so many public agitation has happened and happening there, but see the impact, how much costly it will not handle properly, and then if this will aggravate the matter, then cost a lot as far as financial concern, economic of, see we cannot able to handle that much economy to invest $1 trillion to store 1 million gallon of water. And see, this is the day of this water was released in sea in October 2023 only. So this all was to sensitize you about this audience about the radioactive waste management, its need and concern. Believe me, this type of incidents not going to happen in nuclear medicine because of established regulatory framework. But this is to sensitize you all. If we not handle judicially and as per the regulatory framework, this could be possible, not up to such extent, but up to limited extent. We can lose money, life, center could be closed, that facility should be closed. So with that, I'm now coming to my main topic, that is a radioactive waste. I'm right now focusing only about the nuclear medicine. In nuclear medicine, any material that is a difficult part of nuclear medicine, that whatever material we are using in nuclear medicine, it is radioactive, but once it is used, still it is radioactive. It depends only decrease the concentration or activity. But as per rule and as per our definition, after we decided that this is not suitable for our clinical purpose or monitoring purpose or quality control purpose, we treat it as a radioactive waste. But their activities are still there, not up to that level, but that activities are still there. That's why we need a management, means systematic approach to handle the radioactive waste. So once we decide that this disposable means no intention to receive. We are not interested to receive any concentrated radioactive material for any future use. We decided to relinquish all the control and safety is assured by method other than surveillance. In some cases, a combine of both the method are used to that part of radioactivity is concentrated and stored while the remainder is discharged into the environment after the processing. Means we cannot release the radioactive waste in the environment directly. There is a rules and regulation, and we have to follow the regulatory guidelines. Before this, I'd like to tell that in routine practice, we are constantly generating the radioactive waste. Some as a, like in routine, the way we are doing practice in radio diagnosis, like tissue, contaminated part from patient excretory materials, examination, patient quality control sources, calibration sources, point sources, anatomical mass, it all become the radioactive waste once we intended, and there is no fit for quality control purpose and no further use. So different kind. So because of in the whole process, we generate not only one kind of material, different kind of material like some solid waste, liquid waste, even the gases were, because we are treating patient, cancer thyroid patient with iodine 131. So we are generating the different kind of material, so that we need to deal differently. For solid, our rules and regulation, the way of handling the radioactive waste is different. For liquid is different. We should have like in our facility have a large delay tank to store the solid, especially iodine 131. For gases, we have fume wood with charcoal pitted that trap the iodine 131 and any liquid isotope and gases isotope. Normally in nuclear medicine, in clinical facility, we are practicing with very limited number of isotopes, different types of isotope, but very limited, like moly 99, iodine 131, nowadays lutetium we are routinely using, and fluorine 18, gallium 68, that's all. Luckily, the half-life except iodine, rest have a very limited, less than only lutetium have half-life 6.67, iodine having 8 days. Rest is the few hours to 1 to 3 days, like moly 3 days. So that is making our job is much easier. So what is the principle behind this? Because this radioactive waste is still a radioactive material. So we need to first philosophy to protect the human health and environment. Because we should not release the radioisotope in environment that is going to make cause it might become in our food cycle, may cause to general public little bit exposure. Our motto is to whosoever is not involved in this process should not get any exposure. Patient safety, attendant safety, concerned about the future generation, established because there is a guideline, so we all have to follow the guidelines, legal framework also, to do the regulatory requirement. Otherwise, during the regulatory requirement, AIIMS may shut our the facility, department and center. And third, fourth is like in the waste management. We also work to how to minimize the waste management such a way that interdependently and safety of the facility. To adopt this our fundamental principle, we have decided that this is our fundamental principle on which we are managing our nuclear medicine facility. Radioactive waste shall be managed in such a way as to secure an acceptable level of protection for human health. That's why we are also securing the radioactive waste. That also we are putting in sealed and locked condition. So should not be misused. Theft cases happen in many centers. So radioactive waste shall be managed in such a way that they provide acceptable level of protection to the environment. Only we release radioisotope when the radiation level bring down to almost the background level, so that it would not cause the safety concern for general public and environment. And with this, this is the broad concept of radioactive waste management. And this is applicable in reactor also, nuclear reactor also. Everywhere the radiation rules and regulation and waste management protocol is almost same, whether you are working in nuclear reactor or nuclear medicine department. So we should plan the way waste, our first criteria is to how to ensure that our waste should be come in exempted category. So for this, we used to sometimes pre-treatment required, radioactive material conditioning is required. We can convert it from liquid to solid concentrate and contain. Sometimes we might delay the way we are delaying in delay tank, holding for a certain period of time, 2 months, 3 months, and then after the measuring the radiation level, whether it will come near to the background or not, then only we are releasing. So these are the detailed framework, because the way we are doing every practice should be proper record maintained. That is very much required. So waste inventory is required. We should have a detailed waste management plan for each kind of radioactive material. Think about how to minimize the waste, so that where this is the place where the training of a staff is required. So every activity should be pre-planned in such a way that we should generate the minimum waste, safety assessment, facility, what kind of facility and tools, safety tools available with us, so that we can minimize, how to transport, staff training, that is very much required, and documentation. Each and every step should be well documented, and then we do the quality assurance. Okay. So this is the quality assurance set of procedure we need to do. The way we are in Swachh Bharat mission, we are collecting the waste. It is our duty in nuclear medicine to do a segregation and store the waste. And this is the standard radioactive waste disposable guideline. Upon which category it is suitable, we used to decide whether it's the dilute and disperse. When radioactivity concentration is very low, then there is a rules, as per rule, then we can dilute and disperse. If radioactive material having half-life significantly high, in case of iodine, we used to store and delay and decay. If very high, like in cesium-137 having 30 years half-life, then we used to concentrate or contain for a long time. And then, because in India there is no land disposal facility available, so as per regulatory requirement, we are sending back to the centers of facility where proceeding.
Time is over.
Okay, sir. So these are the waste minimization and segregation. We should do in the that way, and different kind of radioactive materials during the procedure we are generating, we need to handle properly and store them. If not like that, we should store in a lock and key, otherwise this kind of Mayapur incidents might be happen again. So with this, I am concluding my talk. This is the delay time, and there is a guideline for every disposable to how much activity you put in burial, how much activity will do the without any specification in corpus, radioactive waste material in cyclotron. There is some different kind of radioisotope we use. For this we are having the separate burial pit, record keeping is mandatory. So I would like to conclude that this is the important part, that is the hidden part in nuclear medicine practice, and that is the very much serious concern, and this is very much also required to understand the safety issue related with the radioactive waste disposable. Thank you very much for this opportunity. I am concluding with the following conclusion. Due to shortage of time, I could not conclude some waste example and more.
For the next lecture, I'll invite Ms. Manjinder Kaur Dhanwa. She is senior tutor from RSO in radiation oncology at CMC Ludhiana. And she has 31 years of experience in the field of radiation oncology and 21 years of teaching experience in radiodiagnosis and radiation oncology. She will be speaking on the topic system of radiation protection and exposure situations. Ms. Manjinder Kaur, please.
My today's presentation is on the system of radiation protection and exposure situations. I know this is not a good time after the lunch. Everyone wants to take a nap, including me also. So, but we should proceed on my presentation, that is system of radiation protection and exposure situations. In the fundamental safety principles, the fundamental safety objective is to protect the people and the environment from the radiation risk, as AIIMS is also same. So I just want to ask a question from audience from my side, that how many of you have gone through the ICRP publications 103? Can you raise your hands? Okay. So today we will discuss briefly on that. So these standards are based on the following principles. Principle 1 is that is the prime responsibility for safety must reset with the person or organization who is responsible for the facilities and activities that give rise to the radiation risk. Principle 2 is the effective legal and governmental framework for safety include an independent regulatory body that must be established and sustained. Principle 3 is there is an effective leadership and management for the safety must be established and sustained in the organization that are concerned with the particular organizations. And principle 4 is we have the facilities and activities for the justification. And principle 5 is we have an optimization of protection also. And principle 6 is a measure for controlling radiation risk must ensure that no individual bears an unacceptable risk of a harm. Principle 7 is people and environment present and future must be protective against the radiation risk. And principle 8 is all practical effort must be made to prevent and mitigate the nuclear or radiation accidents. Principle 9 is arrangement must be made for the emergency preparedness and the response. Principle 10 is the protective actions must be taken to reduce the existing and unregulated radiation risk that must be justified and optimized. First of all, there is an availability of a well-developed regulatory body alone is not enough to realize the radiation safety in a country. licensee and the users, they have equal responsibility to understand the regulations and implement them. So IAEA conducts many education and training programs. Current regulations makes the hospitals accountable for the safety of all staff and patients who are exposed to ionizing radiation to make sure that ensure the radiation safety. And regulatory bodies in many countries, they are authorized to stop any practice that involves unnecessary radiation exposure to patients, staff or public. This is a module of system of radiation protection. Each module of system will be described briefly here. As you can see, there are 4 of the modules: hazards control, in which the ALARA must be followed, exposure situations, that we will discuss on that, and exposure categories, medical, occupational and public categories, and we have to talk about the radiation protection philosophy. So ICRP discussed radiation protection in this order: type of exposure, we have to 2 types of exposure situations. One is practice, the other one is a intervention. Is that in radiation exposure, and activities that tend to decrease the radiation exposure to people are referred to as a intervention. So background radiation or any situation, these are examples of the interventions. Classification of exposure situations. Now these terms are still very much in use. ICRP in the more recent recommendations, ICRP 103 generalized the system by classifying exposure situations into the 3 categories. Category 1 is a planned exposure situation, category 2 is an emergency exposure situation, and third one is the existing exposure situation. First we will talk about the planned exposure situations. When the source is deliberately introduced and operate, exposures can be anticipated and fully controlled. And exposure situations comprises of source of radiation, exposure pathways, and exposure to the individuals. So, the people under all the categories of exposures are well protected by the explicit rules and regulations. Practices in the sense of ICRP 60, for example, practice of radiology, installation of nuclear reactors are planned exposure situations and are well under control. So in planned exposure situation, decision is made to use a source for particular purpose, and then by decision, it is possible to consider the characteristics of the source and pathways and provide the appropriate control on that. Next is emergency exposure situations. When a planned exposure situations get temporarily out of control due to an incident or an accident, it leads to an emergency exposure situation. So an important consideration in exposure situation is the time frame and the time available to take the protective actions. Any emergency situation requires immediate action in order to avoid or reduce the undesirable consequences. A series of steps can be planned to bring the emergency situation under control in the view of economic and societal factors. Is that a dose to the public brought below a level that is considered ALARA. So a classical example of an emergency situation is the Fukushima nuclear incident that occurred in Japan after a major earthquake on March 11, 2011. Following that earthquake, accident was level 7 because high radioactive waste material was releases over 5 to 6 days. Next is the existing exposure situations. So there are many types of existing exposure situations. What is existing exposure situation? It takes considerable time to return to the near normal situation following an accident referred to as an existing exposure situation. Existing exposure situation are the source already exists when decisions on control are taken. For example, radiation exposure received from the natural radioactivity or natural background radiation. For example, radon gases, doses and cosmic rays. Aircraft crew exposure to cosmic radiation is an existing exposure situation. Cosmic rays does not exist, depends on all, those exist depends on the altitude and magnitude, location, magnitude and graphical location. Radon in a dwelling and workplace an existing exposure situation because naturally occurring radioactivity occurs decay chain that has not been introduced deliberately. So in this figure you can see that on a time scale ICRP 103, this figure shows the concept of the 3 exposure situations on a time scale. So following an accident, the planned exposure situations will, that is under regulatory control, it turns into a unplanned exposure situation by when some incident or accident will happen and you will lose the temporary loss of a control. This is an emergency exposure situations. So when the things will settle down, it turns into an existing exposure situation. So in this figure you can see that this is a radiation exposure under planned and emergency exposure situations. In this you can see that planned exposure and emergency medical exposure existing situations in radiation oncology arising from the man-made source of a radiation that is fully under control in a radiation oncology. So if any accidental medical exposure will happen, then with loss of a control on that situation and it will cause a emergency exposure situations. So on the other side, natural background radiation is an example of existing exposure situations that arise from the natural sources of radiation and generally it is not amenable for the regulatory control. Categories of radiation exposure. ICRP recognizes the categories of exposed individuals, occupational exposure, medical exposure and public exposure. Direct benefit of occupational from the exposure. Occupational exposure assumes special significance since the staff or the radiation protection workers work for the societal benefit. Their risk cannot exceed the risk-based dose limit recommended by the ICRP or the national regulatory bodies for the planned exposure situations. And one is, for instance, potential exposure is there. Potential exposure refers to the probability but not certainty of the occurrence of an exposure. Primary means for controlling the potential exposure is by optimizing the designs of installation and equipment and operating procedures. So for that, restrict the probability of events that could lead to unplanned exposure and restrict the magnitude of exposure that could result if such events were to occur. So sometimes therapy source may fall or leak during the source loading operation that will give rise to the accidental exposure to the personnel who are involved in that. So there are 2 other types of exposure from that categories, acute and chronic exposures. Acute exposures are only involved in accidental situations like nuclear disasters, the people who received acute dose of radiations during atomic bomb explosions that occurred in Japan during World War II. And mainly chronic exposure refers to generally small doses received over a long period of time. In a radiation protection point of view, the main concern is with the chronic exposure situation. So as you all know, principle of radiation protection, while radiation can be used for its beneficial effects on controllable exposure that are under any category of exposure or exposure situation must be justified and optimized, and those limits must be applied to the occupational as well as to the general public. So So their principal optimization introduce some dose constraints in all radiation exposures. So ALARA must be practiced at all the levels. This is the concept of dose constraint and optimization in the planned exposure situations. Justification optimizations requirement to reduce the patient doses in the diagnostic radiology and normal tissue doses in the radiation oncology to ALARA levels. In the imaging, diagnostic reference levels defines that is dose restrictions and dose must be justified. So these are the categories of special medical exposure that involves the comforters and carers who are taking care of their relatives, and some of the volunteers that are in a biomedical research. And third category is of exposed people, relatives in the household of iodine 131 patient who is discharged from the hospital have some residual radioactivity. So reference level for emergency and existing exposure situations. So dose bound set in emergency medical exposure situation and existing exposure conditions, they are known as a reference levels. So process will give rise to the occupational and public exposure depend upon the nature and scale of the accidents. So intervention needs a justification and optimization to reduce the dose. So reference level, ICRP recommends setting reference levels in the band of 20 to 100 millisievert. ICRP defines 3 bands of dose ranges can set as dose constants. So 20 to 100 millisievert exposure, these are emergency exposure situations. So reference level need to set 1 to 20 millisievert, direct and indirect benefits, set the dose constant and reference levels. Training and dose monitoring is needed, but less than 1 millisievert, no direct exposure, so no training is needed. So finally, objective of the radiation protection in medical exposure is whole discussion on the concept, this is the final slide. On the radiation protection in the safe use of radiation in the society as that is developed by ICRP. So National Regulatory Agency produced rules and regulations of in the use of radiations who are responsible for that in the various applications and enforce them to ensure that for the safety purpose. So it is mandatory for all the users to follow the regulations issues. It is not only the responsibility of a government or licensee, it is a responsibility of all the users who are using the radiation equipments.
Thank you, ma'am. Our next speaker will be enlightening us with a talk on biological effects of ionizing radiation. I will request Dr. Sunil Kumar sir, from Regional Cancer Institute, Trivandrum, to please come on to stage, and I will request the chairpersons to please introduce sir.
Dr. Sunil Kumar is working with Regional Cancer Center, Trivandrum, Kerala, as a technical officer in the Division of Radiation Physics since 1990. Presently, he is the Secretary Operations, ISRT. He shall be speaking on the topic, biological effects of ionizing radiation.
Thank you, Chair. Good evening all. I am the last speaker of this conference. This is the last topic. Anyway, the time is, all the programs run in late 3 hours of time, so I will not take much time. And I am really thank you, the organizing committee and scientific committee, to allot a schedule of 15 minutes. I will try to conclude in 15 minutes. Myself, Sunil. I am talking about the biological effects of ionizing radiation. It's a general topic we are hearing all the conferences. I am repeating once again. The topics today I've covered, first is introduction and the cell anatomy and effects on the cell and effect on the human body. we all know radiation. What is radiation? Radiation simply is a mode of transfer of energy. We know conduction, convection, radiation, three modes of energy transfer modes, and radiation is one of them. And what is ionizing radiation? Ionizing radiation is a radiation with enough energy to remove a tightly bound electron from one orbit to another orbit. The radiotherapy makes use of this property of radiation to treat or destroy the cancer cells. Coming on the human cell, I'm not going to the details. Everybody knows the human cell is the basic unit of all living organisms. The cell we can have a nucleus, centralized nucleus, and surrounded by cytoplasm and covered by a cell membrane. And nucleus is the suppose cell is a factory, nucleus is a controlling unit. The nucleus is in nucleus there is a nucleolus, and the space between the nuclear membrane and the nucleolus is called nucleoplasm. It contains chromosomes. It is made up of DNA, deoxyribonucleic acid, and DNA molecules contain all the information required for cellular function that we call genes. Cells of similar nature organize to form form tissue, and the same form of tissue forms an organ, and some organs forms the organ system, and the organ systems makes on organism. That is the structure. And cells can be grouped into two. One is somatic cells, and another one is germ cells. Somatic cells comes from the various tissues such as brain, kidney, and tissue, all other cells. And germ cells are reproductive cells, sperms and ova. And all the somatic cells and germ cells have 23 pairs of chromosomes. And in somatic cells, all the same type of chromosomes, and in sexual chromosome, 22 pairs are same, and another one pair is different. That define the sex. Next is effect on cell. The two types of exposure, one is external and another one is internal exposure. Internal exposure comes inflation, ingestion, and skin absorption. And mechanism of action. There is two mechanisms of action. Mostly the ionizing radiation acts on the DNA. One is direct and another one is indirect. In direct action, if damage occurs on the DNA, that means the photon directly acts on the DNA, makes the damage. In indirect action, the radiation initially acts on the water molecules and forming hydroxy ions, and this makes the damage. This is a diagrammatic picture for the direct effects. This is the indirect effect. And what are the effects of radiation on cells? When the radiation incidence on the body part, whole of the energy is absorbed by the cell through process known as ionization and excitation. The process of removal of orbital electron is known as ionization, and the process of electron move from its original shell to the outer orbit is called excitation. Effects on cell, already told the free radicals react with biomolecules and form DNA damages. And such changes lead to inhibition of cell division, chromosome aberrations, gene mutation, and cell death. What is inhibition of cell division? We know the cell division is a process by which cells are dividing. That is an inevitable process of human and all organisms. When the radiation, the ionizing radiation inhibit or damage the property of the cell division. That means the cell division property is interrupted. What are chromosome aberrations? We all know what is chromosome. Actually, the chromosome is made up of DNA, we know. And radiation can cause mainly on break on chromosomes. The chromosome breaks we can generally call chromatic breaks or chromosome breaks. The picture you can see a normal chromosome. In this picture you can see what are the abnormalities formed by the ionizing radiation. It is dicentric fragments and this actually it's a metaphase. It's a metaphase showing peripheral lymph blood cells का metaphase is showing the chromosome variation because that is the best sample for doing this study. And gene mutation, we know alternation in the formation of the gene is known as gene mutation. Damage to chromosomes or chromosome variations may lead to change the information content of the DNA. That means the DNA content is altered and affected by the radiation effect. And the radiation can lead to cell death as a result of the above side effects. Usually expressed as a fraction of cells surviving after a gene given exposure. The spectrum of dicentric chromosome and ring observed in peripheral blood before exposure to radiation. That is the dicentric. Dicentric means two centromere, and ring means ring-like. There's another abnormality. And the fragment means the chromosomes are divided and cut into fragments. Biological effects on man. The radiation effects we can classify into three: only somatic versus genetic, and immediate or delayed, and stochastic or deterministic. First is somatic and genetic. Somatic effects which occur in the individual exposure, and the genetic effects which occur in the disease of the individual result of lesions in the germinal cells, because it is genetic. In generations it affects. It's radiation effects, somatic, genetic, and the somatic effects we can divide it into intermediate effects and delayed. Immediate effects it's acute exposure, reduction in blood cells, effects on blood forming organs, skin edema, sterility, radiation sickness. It can lead up to death. And delayed is a chronic exposure, acute or chronic exposure. It can cause cancer or cataract. This is somatic effects. These are early effects. Early effects due to acute exposure, large exposure received over a short period of time. Acute exposure, whole body about 1 day, may lead to reduction in lymphocyte, granulocyte count, and radiation sickness, form nausea and vomiting. And transient recover after a couple of days. Severity effects increase with the dose. And the doses about 3 gray, irreparable damage occurs to the blood forming organs with possibility of death in a few weeks' time. In the dose range of 3 to 6 gray, about 60%, 50% of the exposed persons may die within 60 days. And anemia, infection, high fever, and main symptoms of this is perfect. And in a dose of range 7 to 10 gray, cells in the gastrointestinal system gets severely damaged, leading to diarrhea, loss of appetite, dehydration, electrolytic imbalance, weight loss, and high fever. These symptoms are typical gastrointestinal syndrome. Death occurs in 7 to 14 days. At the dose increase, further damage to the nervous system. And in 25 gray, the damage becomes so severe that depression, fatigue, and coma appear, and that occurs within a few hours to 2 days. These symptoms known as the central nervous system syndrome. And early effect received the threshold dose below which the effects do not occur. Beyond threshold, severity increases with dose. These are referred to deterministic effect. The lethal effects of radiation beneficially used for sterilization of medical products, food preservation, and cancer treatments. These are hollow radiation of low LET radiation, less than 0.1 gray, no lethal effect, and above 0.1. Chromosome aberrations are detectable, and above 0.5, above effect plus, transcription, WBC count, granulocyte count. Above 1 gray, all the above plus, nausea, vomiting, diarrhea, loss of appetite, radiation sickness, recovery probable, and all the 3 to 5 gray, all the above with increased severity, death of 50% of the exposed population in about 50 days, severe, and 5 to 10 gray severity of effects increases almost 10% death. That's the high dose. Sir, local radiation for low LET radiation, 0 to 0.15 gram testis thermal sterility, 3.5 to 6 testis permanent sterility, 1.5 to 2 ovaries temporary sterility, 2.5 to 6 permanent sterility, 3 gray hair follicles, and 5 gray eye cataract after 5 to 10 years, 6 gray skin depilation, and 10 to 20 in burns, blisters, wounds, that of tissues, this necrosis, permanent necrosis. Late effects. Persons recover from early effects, they still develop late effects. Exposure to low levels of radiation over a period of time may produce late effects. Cancer, fibrosis of tissue, and cataract, these are examples. To conclude, overall, all effects of radiation exposure depends upon dose rate, duration of exposure, and radio sensitivity. That's the end. Thank you.
The session is now open for questions. If there are any questions. If there are no questions, then we close the session and hand over the mic to the organizers.
Thank you.
Thank you, sir. Now we shall proceed towards the felicitation ceremony of our speakers for this session. I would request our 3 speakers for this session, Dr. Dhananjay Kumar Singh, Ms. Manjinder Kaur Kanua, and Dr. Sunil Kumar to please come to stage. And I would request our chairpersons to please come forward to felicitate our speakers. A huge round of applause to all of them. I would request Suruchi Jain ma'am to please felicitate Ms. Dr. Dhananjay Kumar Singh. Now I would request Rajesh sir to please present the memento and service. I would request Suruchi ma'am and Rajesh sir to please present the memento and certificate to Dr. Sunil Kumar sir. Thank you. I would request Mr. Jayakumar A, Deputy General Manager in Labs, and Mr. Gyazuddin Bailey from ISRT Jammu Kashmir to please come up on stage and felicitate our chairpersons for this session. Now I would request Mr. Gyazuddin Bailey sir to please felicitate Suruchi Jain ma'am with the memento and certificate. request our honorable chairpersons. I would like to thank our honorable chairpersons for chairing the session. Thank you.
Now we have a small presentation from United Imaging, followed by a trade talk by AIIMS, sir.
Universal challenge. How can we provide high-quality healthcare that benefits more people? United Imaging was born to take this challenge head-on. Driven by the mission to bring equal healthcare for all, we are committed to achieving the vision of leading world healthcare innovation. Leveraging the world's top talents, United Imaging is establishing a global platform for synergistic innovation. Focusing on prospective research, United Imaging Central Research Institute is committed to solving global medical problems. Integrating cutting-edge technologies, UIH Cloud is building an interconnected healthcare ecosystem, setting up global production bases. United Imaging is focusing on lean manufacturing of all products. Designing an excellent user experience, United Imaging Corporate Design Innovation Center is redefining industry standards. The world's first total body PET CT Explorer reveals unprecedented 4D dynamic total body imaging and creates infinite possibilities for clinical and scientific research. The world's first whole body 5 Tesla MR, UMR Jupiter, and the ultra-high field preclinical MR, UMR 9.4 Tesla, form a pair of equipment that accelerates the translational path from preclinical research to clinical application. The world's first 75 centimeter ultra-wide bore 3 Tesla MR, UMR Omega, can easily accommodate large patients and offer a better scanning experience. The high-definition top PET MR can synchronize PET and MR real-time data streams. The world's first fully integrated CT Linux redefines precision radiotherapy. The ultra-premium 640 slice CT scanner provides unlimited heart rate imaging from a single cardiac cycle. The low-dose 3D mammography system provides comprehensive care for women's health with less radiation. Innovation, now and forever. United Imaging is building an intelligent healthcare ecosystem and leading the future of healthcare. United Imaging Intelligence empowers full mode equipment and clinical and scientific research through AI. United Imaging Microelectronics focuses on the development of high-end medical chips for the entire portfolio. United Imaging Surgical Tech creates overall healthcare solutions covering prevention, diagnosis, treatment, and rehabilitation. United Imaging Eye Healthcare builds a new ecology of precision medical imaging services. Perceive more. Provide more. Access more. United Imaging. Passion for change.
Thank you very much for watching the video. I would like to call upon Mr. Sai Kiran, Head Marketing Divisions, AIIMS, for the next presentation.
Over to you, Mr. Saikir.
Good afternoon, ladies and gentlemen. I am Saikiran Matraga and I represent Andhra Pradesh MedTech Zone, India's first integrated medical device manufacturing hub, which is situated in Visakhapatnam. So I want to take you all through a small journey of AIIMS through this video.
Thank you, Saikiran. AIIMS is hosting our next virtual conference at Vaishak. Now I would like to call upon Mr. Mukesh Jain for the panel discussion, RTT, National Model Curriculum, present status and way forward. I would like to call upon the panelists, Mr. A. Selvakumar, Mr. Suresh Malay, Mr. Rakesh Kaur, Mr. Majidar Kaur, Mr. Ramesh Sharma, and Mr. Prakash Kumbharkar at the stage.
Good evening all. Today we are reaching about the last session of this conference, and then we have the final conclusion of this conference. So in our panel discussions we have the RTT National Model Curriculum present status and the way forward. As we know, we are aware that in 2012 the PHFI, the Public Health Foundation of India, submit a report to Indian government about the status of different allied healthcare professionals. The report is generated to mark the variance in educations or educational system for allied health professionals, and ISRT is also continuously striving to in its different representations during course of time to enhance the quality of education of allied health professionals and to empower the allied health professionals, especially the radiotherapy technologists and radiation technologists. So in view of continuous ISRT representations and the report published by the PHFI, the National Central Government of India in 2012 realized that there should be some kind of uniformity in the curriculum, and there should be a pathway for development of allied health professionals. So in this view, the ministry decided to provide a unique framework for RTT and radiotherapy technologist educations, including the other allied health professionals during this time. So the ministry identified the 12 leading allied health professional courses, in which out of 12 they prepared 8 model curriculums, and it is published in 2015. But the thing is that these model curriculum are of the advisory nature, not the implementary nature or the mandatory one. In absence of a regulatory authority, not in India, to implement these kind of curriculum to the ministry. So in this view, and continues the representation of ISRT, in 2021, the ministry produced a bill called NCHP bill, that is National Commission for Allied Health Professionals, in line with the ISRT representations and representations given by the other allied health professional societies in India. So this led the government continuously stress the government to create a uniform pattern in India for allied health professionals to develop their competencies and to develop and to empower them to create their job profiles based on their competencies and the experience of the field. So in this way, in 2021, the NCHP Act passed by the Parliament, and the Interim Commission was established that start working in 2022, and in the initial startup, they also realized, the Commission also realized to have the uniform curriculum, as the curriculum prepared earlier having might some kind of lapses or some needs the improvement during the course of time, as it should be a competency-based structure. As we are aware that during course of time there are many scientific upliftment or scientific knowledge is gaining day to day time. So there is a dire need of to develop a complete curriculum that having the competency or that can scale up the professionals, not only the regular teaching in which we have to do some kind of study and need to present that study data into the field, they need to perform in the field, in the industries. So it should be industry oriented, it should be a person oriented, and it should have the inculcating the present status of the practice. So in this view, the ISRT is also striving hard to empower the allied professionals, especially the radiation technologists and the radiotherapy technologists. So firstly, I would like to ask Selva sir, that's what's the ISRT role of empowering of RTTs?
Very good evening. Thank you, Mukesh. You've given a good introduction about this path, how this carry forward this curriculum formation and what are the activities taken place in the past nearly 1 decade, say around 8 years now. And really ISRT as a professional body, affects professional body taking care of all the radiation activities, radiotherapy, radiography and other areas. In 2015 when Nadaji is in our forum, he know about our activities and skill. He invited us also to take part in that activities. Initially, central government is not very much aware of our activities. Once he know about this, then he asked us through Ministry of Health, and they contacted us, and we given a representation to this. And our expert team from our ISRT given a lot of suggestions in this modern curriculum in each and every field. And really, especially for it basically that modern curriculum consists of the scope and need for the allied healthcare professionals in the Indian healthcare system, and how it can be taken care by competency-based curriculum, how the curriculum can be formed. Because previously all aware that each and every institution has their own curriculum. Only the ARB get control of that only radiation safety part, other things not taken care of. Each and every institution has their own curriculum, and when the technology is coming to the field work, there are different scope of knowledge and activities. To make these things, it's made this competence-based curriculum for the taking care of the modern activities of the radiotherapy system, and it is learning methodology how we can take care. It is like a good system of teaching, but now how the modern system, how the teaching can be improved, and what other things can be involved in these activities. These things are included, and assessment method, how we can assess for all the after the learning is over, how we can assess with the theory part and the practical part and viva. All things are included in this forum. And in this chapter 5 of this curriculum model, describe about the job descriptions, how the jobs can be given to what level of curriculum based there. It's a bachelor degree or the master's degree or the because we can't forget the diploma holders also. So those who have the diploma holders with stipulated period of experience, they can get into that higher position, or in the same way they can take care in the academic division also. Not only this working force in the hospitals, they have to take care of the academic forces also. These things are taken care in the point of the syllabus making. And ISRT is really given a lot of inputs in each and everything. And with recently with the 21 curriculum model also, these points are taken care. And with the one additional chapter is enacted in this to take care of the modern instruments like linear accelerator, updated things, image guided processes and all nowadays is added. And the QA and QC is very much important for those who are operating the equipment. Without this, we can't do that. So ISRT is taking care of all these activities.
Yeah, rightly said, sir, that the efficacy and the effectiveness of any educational program depends on the its curriculum, and it needs to be followed in that similar fashions. So definitely ISRT made tremendous efforts with regards to the creation of the curriculum, and as you told that various steps taken by the ISRT to empower the RTTs and radiotherapy technologists in the field. So in this way I would like to ask Suresh that what efforts ISRT have made to enhance the RTT competency and the education.
Thank you, Mukesh sir. First of all, I wish to congratulate you for initiating this type of very good activity. Actually, this curriculum and some professional aspects, including the model curriculum or standardization for radiotherapy, has not been explored. It is underexplored or underestimated. It was in 2014 that, as Sylvia was told, it was in 2014 that the Ministry of Health, under public, you also come HFI, Ministry of Health has initiated the standardization of curriculum for professions. But radiotherapy, there was a committee under the Ministry of Health, Dr. Ari Al-Rizvi, he was the Joint Secretary, and task force was formed. At that time, I was invited for a workshop in AIIMS, not in this AIIMS, Amrita Institute of Medical Sciences, but unfortunately I couldn't be a part of that curriculum committee due to some technical issues. I think they want some, I was not from faculty side, they want some faculty. But I came to know that this curriculum was, the curriculum of medical radiology and imaging technology was led by a technologist and a radiologist, chairperson 1 and chairperson 2. But unfortunately, this curriculum of radiotherapy technologies was developed by medical physics department, so dominated by medical physicists. So what really happened? Maximum control of syllabus and maximum control of learning methodology, and I don't know why it has happened. Then maximum control of career pathway was happened. It may be accidentally, or if I don't know, without having any reason, we cannot do, we cannot comment anything. So what really happened? The nomenclature itself has been changed. If a person giving therapy is a therapist. If a person treating a patient with a physical forms, heat or something like the molecular waves, he is a physiotherapist. But Ayurveda is an Ayurveda therapist. But really, while coming to radiation part, he is a technician. I don't know what is it. WHO has developed that radiation therapist is a basic form of nomenclature, or a standardized nomenclature for radiation. Those who are imparting radiation therapy. But it is not implemented in India due to unknown reasons. First thing, career pathway was also controlled up to chief radiotherapy technologist. In India, we have radiotherapy manager, Mr. Selva Kumar is there, and director of radiotherapy is there, department administrator is there, but it is not included. While going through, I didn't go through in detail medical curriculum because I have practiced almost 5 years, but at that time, LINAC, up to LINAC. Beyond LINAC, I don't know, I didn't update, but I went through that, but I realized that it is not up to the benchmark, or not yet up to the international standards as we have done in medical radiology and imaging technology. First thing. So what ISRT has planned, ISRT met the curricular committee, national level curriculum task force members, the chairman, he was IIS, he was from IIS. Then he explained that it is not their fault, it is a fault from the faculty members who have been nominated by the Ministry of Health or by the institution. I think the very same mistake is happened again. So I hope we have a Herculean task to modify these things, one part. And second part, in radiotherapy also there are lot of underqualified hands.
Yes, sir.
Underqualified hands without having graduation or diploma, even have a diploma. I don't know how the NCHP Act has to give the license or registration for the members practicing before the 27th of March 2021. But there should be some exams, there should be exit exams and QT exams. So as a professional body, it's our obligation to empower them for the exams and to teach them. At present, radiotherapy, AERB was, earlier days, AERB was conducting some sort of radiotherapy certification programs to give some sort of empowerment program or skill development test training course underqualified therapy technologies and to make them regularized, to get them regularized. The very same thing we will take care, not under the ambit of AERB. At the same time, it will be coming under the regulatory framework of NCHP, National Commission for Allied and Healthcare Professions. What further we have to understand that as on after the 21st, 27th, 28th March 2021, AERB has no powers to regulate the courses. That we have to understand, because Government of India, Parliament has made a milestone legislation. If anybody is duplicating this powers conferred by the Act, it will be the cognizance of law. So, the Ministry of Health has clearly mentioned that AERB need not to dare this approval of courses, because this is not coming under the regulatory framework or regulatory ambit of AERB. It is coming under the NCHP. Yes. So we have to make it clear, as a professional body, ISRT is addressing this concern and we are approaching the government. But why we were silent? Because there was no national commission, and Indian commission was there. But by next year, commission chairperson was appointed. By next year, a regular commission will be appointed, and we will address our genuine concern first. And first part, we will modify the curriculum. There is no doubt. And third part, we will conduct more and more workshops, training programs, and this type of exit exams or MQTs. As a professional body, we can ensure that. Thank you.
Thank you, sir. Rightly said by you that ISRT is continuously striving to implement for the RT as well as RTT. And you rightly said that many areas are still unexplored, needs to be emphasized to develop the competencies, to develop at par the level of internationally levels. As per concerned with nomenclature, you rightly said that we don't know what the confusion is. The WHO in ISCO codes, they describe the same job profile for the RTTs in that manner, but might be still some kind of confusion, or might be the RTTs are not well represented in formation of that kind of curriculums that's having some kind of lapses. So if we look at the scenario and continuously striving of the ISRT to develop the competency-based curriculums, we recently done it for imaging technology. As you told that it's done by our 7 members, and they beautifully designed the curriculum. It's exceptional in the contents and exceptional in the way looking forward for another 10 years. So it's a curriculum, it's for the ideal curriculum for anyone to follow, and we hope that ISRT will set the landmarks for RTT also in future. So in this view, the ICHP also revised the RTT curriculum, and we get to know that in present model curriculum, I would like to ask Rakesh sir, yes sir, please.
I will add one more thing.
Yes.
In professional practice, we should have some interdisciplinary trainings also. That should be incorporated in curriculum. Because while radiotherapy planning is there, I have that lot of we should know diagnostics, CT simulations, lot of things we have to do. A good radiotherapy technologist, as Dr. Mahajan has told, a good radiotherapy technologist shall be a good diagnostic radiographer. Without having the knowledge of CT, MR, and cross-sectional imaging, especially your image guided. I am telling your means, I am not telling your IGR, image guided radiotherapy, IMRT, and whatever it is, we should have good, thorough knowledge of diagnostic imaging, and we have to understand that radiotherapy and radiodiagnosis are not as separate questions. We are coming under the umbrella term of radiological technology. We are a single family.
Yeah.
I don't know why it is only in India we have bifurcated. Professional practice is bifurcated, but at the organization level, and Australia, UK, US, it is coming under single professional body.
Yeah, one can say that's one kind of specialty that we are having being a radiation technology that might be an RTT. And also, you said that in that view that NEP is also addressing this issue.
Yes.
NEP, new education policy. They are providing different. If you are giving certain kind of degree courses, you might be expertise in certain kind of field. Might be imaging, RTT. May have the add-on courses for the imaging technology. Might be a CT technology, or might be MR technology, or might be IGRT, or might be mold room settings. Whatever competencies he want to develop extra, he can have in that manner as a value-added courses as per NEP 2022-20. Sorry, that's yes, sir. Christian, we want to.
Not only the radiology, every profession we need some multi-skilling in future, because without having the knowledge, comprehensive knowledge, we cannot survive, especially in the era of artificial intelligence. What I want to add, the curriculum of radiotherapy, MRRTP, shall be modified with the emphasis for planning purpose, with the diagnostic imaging, coupled devices, and so a lot of things. Especially we want to add some sort of social, I think, counseling to patient. I think it is not meticulously planned. It is not meticulously developed. I don't know who are behind this. With the very same curriculum, cut and paste, and some pages added. I don't know what exactly they meant. So we have to intervene. I'm not taking much time.
And just to move it faster, due to limitation of time frame, that's I want to ask Rakesh Kaushal. That's about the model curriculum. We know that many scopes are there to improve it. Is present model curriculum is fulfill the requirement of infrastructure for RTT, education, and perspective of fulfillment demand versus supply ratio.
First of all, I must thank you for choosing this topic. It's a very relevant topic, and it's a very relevant topic that we should address all the issues what we have. Before starting, we should know what is the infrastructure in our country right now. As per the data 2021. There are 427 centers of radiotherapy as per 2021. Maybe it is more than that. And there were almost 670 linear accelerator tilt therapy units, of which 180 were the bulk units, and the rest of these were the linear accelerators. That was around 500 were linear accelerators. And in addition to that, we have certain advanced machines, units that was gamma knives, tomotherapy units, cyber knives, and proton therapy units, which we have two in India. We have two tomotherapy units. And also in addition to this, there are almost 320 brachytherapy units. Though brachytherapy units where RTTs are using very less access, we can have say less access for those units. But the challenge here is that that existing linear accelerators or the high-end machines we have, but we are short of almost 700 machines are short as per the WHO data. WHO data says at least one teletherapy unit for 1 million people. So in that case, we should have 1,400 machines, 48 teletherapy units or high-end machines, which is not available in this. And if we go to the rural area, there is the situation is very bad as far as the infrastructure is concerned. Though as per the data, we see that new installations are also going on, but as per the data, 40 units are added to and 15 units are commissioned. And the population is also growing. So if we see the demand and supply, it remains the same, ratio remains the same. There is no much change in that. And particularly in the rural areas, no units are so this one. Now, if we see on the other issue, we can see that the infrastructure in terms of the educations, we have that there are 185 teaching institutions as per the AIIMS data which they have issued in 2021. They conduct diploma courses, PG diploma courses, they have BSc and MSc courses, and even their PhD courses are being conducted in some other sectors, and you are one of the persons who is doing the PhD. And we have, we produce almost 500 to 600 students per year, and we can absorb only 200 or 300 students. The rest of the students we can't absorb because there are short centers, short of the machines. This is a big gap.
Yeah, it's clear that we need to empower the infrastructure also to teach the students to become a competent RTTs.
So there's a big gap with this one, and teacher-student ratio should be 1:10.
There is huge demand of RTT, but it's not RTT, it's the competent RTT. Otherwise, you will be, you need to survive in the field. In absence of the desired competencies, which can be achieved by the required infra, can be fulfilled for educational institution as well as the teaching institutions.
Yes, one more point just I want to add. But there are this RTTs when they seek a job, MSc students and diploma students are being put at the bar. So which is not fair. That MSc students should be put in the research work, or they should be offered the dosimetry posts, or radiation managers, or they should be observed the quality assurance test also, which is not being done, which is very unfortunate. I don't know what is the US association doing for this. As Mr. Suresh has rightly said, there has been a parallel development in the field of the imaging. And if we have learned about the imaging, because radiotherapy is incomplete without the imaging, because we can't delineate the tumors well, and that we can't place the beams well. So the imaging part we have to learn. We have to learn. A deep learning should be in the part of the imaging also.
As per the educational, that's the competencies also should be there, and the educational profile as well as the experience profiles can have the different job profiles and job roles for the RTTs in the fields. So in this view, I would like to ask Majinder ma'am that what is the scope of practice for RTT locally and globally in the era of AI?
Good afternoon, Mr. Mukesh, for giving me this opportunity to talk about the opportunity in as a radiotherapy technologist. Yeah, it is not fair actually. A physiotherapist, they are called therapists. So therapist is to treat the patient. As a radiation therapy technologist, we are also treating the patient. So in abroad, it is already radiation therapist. They are appointing as a radiation therapist. Even few of my students, they are in UK. They are doing plannings and contouring also in the TPS. So all the work they are doing. So I'm very happy to see that my students, they are doing that much work. Hello. Yeah, but in India, what we are doing? So we are not getting opportunity to work in, even we are qualified also, then also we are not getting opportunity to work as a radiation. Even in the model curriculum, nomenclature in various this sectors. So there are level 4, level. So level 4, level 5, level 6, level 7 to 8. So in my institution, okay, in my institution also the same things they have given us for the promotion factor. But from last 2 years, we are fighting for that, and it is not implementing. So my question is that how we will implement this if we are qualifying accordingly. And one more thing I want to tell that the diploma should be banned, because the diploma holder and BSc, MSc all are getting the same job profile and the same salaries. So we need to implement, this is very good model curriculum that is there in the nomenclature of the levels, level 4, junior radiotherapy technologist, should be diploma in a radiation therapy, it is okay. And now more of the places, most of the places diploma is not done. So ARB wants bachelor course only.
Yeah, it can be scrapped up during course of time, and for the existing workforce, we need to provide some sort of chances by introducing some kind of bridge courses, or might be some kind of performance-based incentives we can have to satisfy the job profiles and also the competencies. So in this view, I would like to Mr. Ramesh sir, that is the content and the syllabi of content of the syllabi distribution, and any needs any updation looking to the present scenario.
Yes, sir. Thank you, sir. As per the model curriculum, most of the paramedical courses are unified by their unique syllabus, unique qualification, and their unique tenure. So, as per it, most of the universities and most of the colleges are adapting the syllabus given by as per the model curriculum. And in that syllabus for RPT, I found some limitations that for most of the degree courses are divided into 8 semesters. First 6 semesters are for the courses, and for 2 semesters it is for the purpose of internship. In the radiotherapy course, in first semester, we can find that there are 10 papers are there, and the course is quite difficult also and very lengthy. 10 papers are there, and when a student get admission in the college, first 1 or 2 months are consumed in adapting that environment. And after that, when he finds that 10 papers are there, and the content of these 10 papers are also not very less, they are very high. So I want that the course must be from easier to harder side. But in RTT course, as per me, the course is going from harder to easier side. So there must be some, it needs some changes in the syllabus. For example, in the first semester, there is a course of 10 papers are there. One of them is biomedical waste management. If a student who don't know what type of biomedical wastage are producing in radiotherapy, how could he understand? How can we dissipate that wastage? So there must be some procedure, or after it should be included in the 3rd or 4th semester. One is research methodology is there in the first semester. I think it should be in 3rd or 4th semester. And in the second semester, for the first paper, elementary mathematics and physics, for this paper, the content is not as per the degree courses. And for human anatomy and physiology, for a RTTM, anatomy physiology should be strong. But anatomy physiology course is there, but pathology course is not included into the syllabus. So it must be there.
So rightly said, sir, that the curriculum design should be in a way that to improve the gradual understanding of the students, and it should be practice oriented. What practice we are supposed to do, and first what we need to learn, that should be incorporated first. Then the advanced modalities can be taken up later on, and also the content of the syllabi, the document for the framework of the practice. So it should be clearly defined what to teach and what to empower the student. And in this view, that's by analyzing the present model curriculum of RTT, that's I would like to ask Mr. Prakash Shukrakar, that's how you rate the present curriculum and the scope of its improvement.
Yes, current curriculum, that is, yes, there are the scope of improvement. We can also add there are certain factors like the patient care, because we are dealing with the patient care. So we have to emphasize a more practical approach in the patient care. How can the development in the current scenario in the patient care? Because in the radiation therapy is the biggest role play in the cancer treatment. Another issue, yes sir, told that the research and development. Yes, we are the lack of, there is a very less the development and research program for our Indian scenario. Because if you compare with the diagnosis, the nuclear medicine, many of the technology doing the PhD, but we feel our radiation therapists, I think you are two people only doing the PhD, but why not should be our radiation therapist? Where you lack our dignity or the professional, I think this must be the highlighted topic which should be implement our syllabus. But yes, we are putting the syllabus, are you going to implement it successfully? Then another issue, if you talk about the AI advancement technology, now if you think about the technology to technology comparison, it's my point of view. If you're talking about the advanced treatment modality, if you tell that to go and simulator and do the 2D planning, now this today's technology not doing the 2D planning. It's very difficult to again is the education gap. It should be understood. Don't forget our the history where you come and now where to reach. So I think we have to revise only is possible, only the continuous education program that we are expecting, keeping the uplifting is our professional, national, international level, and I think they give the very good platform to share our thought, knowledge, and not internationally. But I think this is our lack. Then again, we have emphasized a more practical approach, not theoretical, because we are dealing with the more practice. So if you collaborate as a multidisciplinary teams like radiation oncology, diagnosis, we can more and more emphasize on more work for the outcome for the patients. And last one very important, as I feel, why not should our radiation therapists do our post will conducted? Why should we require the medical physician?
Yeah, thank you, Prakashji, for quite good insights. That's in conclusion, that we get to know that the present curriculum stands many scope of its improvement, and definitely with the help of ISRT and the fraternity, we can do it in our future. In future. So with the help of ISRT, we'll definitely do. So we understand that any curriculum or any study designs should be framed in a way to reach on the top by using the stairs, not by skipping the stairs. So in this view, ISRT earlier prepared a fantastic model curriculum for the imaging technology, and the lead role taken by one of our ISRT member, Mr. lead role taken by the Shashikumar Sethi. So it would be quite enough to get his insights on the curriculum development. If he is here, may I ask? Yeah. Yes, sir, please.
Thank you very much for the opportunity. Respected Dr. Rajesh Malik sir, respected panelists. Myself is Shashikumar Shetty. I am the assistant professor and head of the Department of Medical Imaging Technology from NITA University from Bangalore, Karnataka. So I was the part of this curriculum of the MRIT, Medical and Radiology Imaging Technology. In 2015, as we are already discussing, 2016 it was prepared the draft. But later when we were preparing it, I saw that lot of lack of subjects. Right now you mentioned about missing pathology, there are a lot of subjects. I am from the background, I was a part of the board of studies of allied health in my institution, and I was also part of the academic council of the institution, because our under my NITA university there are 49 institutions. So many times I went through the curriculum, so I know what and all things were required. This was helped me to prepare this draft of the MRIT. So, by the way, I must thank ISRT and especially Suresh Mallet sir, who recommended my name, because he was mentioning today, even in the introduction or in the inauguration also, he mentioned about my name. I was really emotional. So it was a great honor and opportunity to be part of the curriculum. And in our curriculum, even job description, required faculty qualification, even model checklist for the examination, even for the journal club, seminars, if it is there, how to be adapted the marking of this thing. We have provided the checklist of that, and as well as advanced. Now we wanted to have the advanced, even artificial intelligence and the interdisciplinary subject. I saw that someone was discussing about the interdisciplinary subject. Even that also were there. There are a lot of questions when I was asking about, no, you should have the pathology subject, you should have the biochemistry. Why you want it required? MIT, not required. Medical imaging, not required. No, I said, now you don't think about technologist or radiographer level and all. We should think about something beyond that. If the person have a basic knowledge of the biochemistry, pathology, microbiology, then when the person pursue master degree, it will be very helpful for the research. Because my students, I'm doing PhD, part-time PhD in my university. I'm doing work on biodosimetry, where I'm going to see the DNA damage with the different exposure level, all those things and all. So my students also will be selected certain, they should have the knowledge of that. No? Unless they have the knowledge in the bachelor, how can they do it in the thesis, in the PG? That was my question. So luckily, there are some of, after a healthy discussion, then they agreed to be part of that. But still, we have kept value-added course opportunities if you wanted to have the value, because that's most important nowadays, you know that about value-added. But during PG, there was a lot of discussion about why can't we have a specialized master degree courses about CT, about MRI, about interventional radiology. I was completely opposed for that. The thing is, in India, it's not easy to have the independent specialized course at present. That was my suggestion. See, someone completed about the CT master degree. So, will that person will get as a designation as a faculty in CT? No. Even now, whoever is completed as a short-term courses after bachelor degree, 6 month or 1 year courses, you tell me one person as appointed as a CT technologist, as appointed as an MRI technologist. No, they'll be given as a CT technologist or radiographer as a designation. So I was opposing that. And moreover that, someone has completed CT, someone has completed an MRI master degree. One institution going to appoint faculty, will they appoint for CT one person, MRI one person, for interventional radiology one person, will they appoint? It's impossible, because we have to think about the smaller institution also. That was in my mind. So I was completely opposing. But later I gave an option to them, why can't we have an elective? Elective in the sense, first 2 semesters will have a general subjects about positioning, procedures, interventional radiology, all those things and all. And the 3rd and 4th will have the elective of CT and MRI and breast imaging. We have kept the 3 different options. Breast imaging. There are a lot of questions also. Why we have kept the breast imaging? Why can't we have a mammogram? I said, yeah, 2 minutes, I'll wind up. So I mentioned that because we are thinking about, Suresh Mallet sir always used to mention, why can't we have neuroimaging in MSc and all. So this is the step, on a small step we kept as a breast imaging in the elective subject. So that is a small step we already kept which is supposed to be happen in after 10 years, that already we captured. So there are, I wanted to adopt the OSCE, you know all of you about OSCE implementation, or elective subjects in master degree. Those things and all, it was not possible. But anyway, I'm happy that even well appreciated by the radiotherapy panelists also. It was well prepared by the MRIT curriculum. With this, I thank especially Suresh Malia sir for providing me the opportunity to be part of the curriculum committee where he recommended my name. With this, thank you very much.
Thank you, sir, for providing valuable insights. So we get to know that how the ISAT playing a pivotal role in framing not only the professions, also the educations and the competencies. And for this, so I would like to thank for this being with us. And Dr. Dhananjay is want to put, so in 1 or 2 minutes, might be.
Thank you, President sir, for giving me this opportunity. First suggestion is to simplest way to start comparing the radiotherapy syllabus and curriculum with radio imaging. First thing. Second thing, abolish immediately, fight for that diploma, post-graduate diploma. That is cannot be accepted at this moment of time. And the third is to think about the IGRT and IMRT in elective courses, the way Sasi suggested. Because I already personally suggested to the commission that in radio imaging technology, 2 more elective courses should be adopted. One in intervention radiology and second one is nuclear medicine. Because nuclear medicine is part of curriculum of bachelor and master both in radio imaging. So this quick suggestion. Thank you. Thank you for this opportunity.
Dhananjay sir, thank you for suggestions. And if you look for NEP 2020, it's also described about the addition of the discipline-specific courses in the curriculum, and there should be 4 discipline-specific courses and 2 skill enhancement courses and 2 ability enhancement courses are there. So if we move towards NEP also to make a competent curriculum of allied health professionals competent to NEP, it will definitely incorporate your suggestions also, as you suggested. So with this remark, I would like to thank all the panelists to be here. I would like to thank ISRT to provide us opportunity to discuss over here in a big platform, and also the Suresh sir for continuously encouraging us to keep look forward. Thank you all, and thank you organizers for providing us chance to be here for good academic extravaganza and also the good academic and extra activities. Thank you.
Thank you, sir. Thank you very much for the discussion about radiotherapy. And now I would like to call upon Ms. Nahida for taking up the stage for the valedictory function.
Thank you so much, sir. Good evening, everyone. Hope you all had the wonderful 2-day event here in this Bhopal campus, and I congratulate you all for successfully conducting these 2 wonderful events. And I would like to have a big clap for these organizing team and the efforts that have put for this event. Thank you so much. So with this, I would like to say that, of course, it is not the destination but the journey that counts. So it was our destination to conduct the event, but the journey what we had for these two days was tremendous and incredible. We learned a lot. There were most of the presentations where we learned so much, and I think everyone in this hall is going with a full mind, with fully loaded mind, because that kind of presentations you encountered here in this presentation. So I would like to call the following dignitaries on the dais for valedictory function. It's my privilege to invite our organizing chairperson, Dr. Malik, on this stage, and the man behind this journey, with, of course, with the people with him, and he has put all his effort for this program, and he only knows from where they have started and where we ended it now successfully. So thank you so much. So please take your seat here. May I call our organizing secretary, Mr. Abhishek Sherawat, the one more person behind the successful of this event. So please come and take your seat upon the dais. I call now Mr. Deependra Vishwakarma, Finance Secretary, one more pillar for this success. So please come and take your seat on the dais. From Scientific Committee, who had put their effort from receiving all the presentations and looking into it, such a tireless, I would say, the journey. From that, I would like to call Dr. Radha, Ma'am, Chairperson of the Scientific Committee. Can we have a round of applause for Dr. Radha for her efforts, tireless efforts for this program. The convener from the Scientific Committee, Professor Paneer Selvam sir, one more pillar for this journey. Sir, please come on the dais and take your seat. President ISRT Paneer Selvam sir, the man behind, one more the person behind the success of this program. So please come on the dais and take your seat. Okay. Selva Kumar sir. General Secretary ISRT Suresh Malayak sir, the one man person from having this idea that I have to conduct an NCIRT program, NCISRT program, and then decides where it has to be conducted. The one person who initiated this program, and we ended up having a successful event. A big round of applause for our General Secretary. Of course, all our dignitaries are on the dais now. Of course, they would be having the picture of this event, how they started and how we ended up. So I would like to call now Dr. Malik on the podium to share how and to give the closing remarks on this event. So please come and share your thoughts for this program.
Thank you so much. I'm totally unprepared for my closing remarks, because I told Suresh, I said, I'll finish my job, you take the valedictory. He didn't tell me that I'm supposed to speak for a few minutes. Anyway, but it had been really a wonderful experience for me, hosting you all and organizing this conference for the technologists. A real brilliant experience. Not only for me, even for the institution, because this was the largest gathering of a conference that we ever held in AIIMS Bhopal. And I'm so thrilled that I never for 1 minute felt that you are different from me and I'm different from you. So that is probably the best part of a participation that you can think of, you can dream of. This has given me good memories for future, and I'm sure the association that we have developed with the ISRT and the ISRRT now would continue for future. We would still be holding hands with you whenever you need us, wherever you need us, for organizing such more events in future. And let those events come out with more volumes. This time we were 600, next time let's target 1,600. And let's have a much more elaborate program on a much more elaborate platform out here at AIIMS Bhopal. Wish you all success, and thank you for giving us this opportunity of hosting your program. I hope we could do things as per your standards, as per your expectations. There must have been a few errors somewhere or the other, but to err is human. We'll always learn by our errors and try to fulfill them and make them better in the future endeavors. Thank you, Suresh, for being here. Thank you, Daniel, for giving us this chance. You were the one who persuaded me to say yes and nod my head like this when you came to me the first time asking me for a good round of applause to you. Had this man not been there, probably Bhopal would not have hosted this conference. So thank you so much and wish you all success for your future endeavors. We are always with you whenever, wherever. God bless.
Thank you so much, sir. And I could notice that the audience were responding you that it was an excellent hosting from your end. So thank you so much. And I will follow the same and I will call Mr. Abhishek to share his experience on this event.
First of all, thank you for coming. I would like to thank Dr. Malik, Dr. Rana, and all our chairpersons and ISRT team, AP team, and all previously organizers of different conferences to take us to this point. So I would like to conclude my talk early because I'm looking time basis, but definitely it will be good. I'm thankful to you I'm thankful to all of you for being with us. Thank you.
Thank you, Mr. Abhishek, for sharing this. And may I call now Mr. Dipendra to share the same feeling?
Thank you, Naita ma'am, respected sir, ma'am, and other dignitaries. Basically, my part is belongs to finance, but overall event managed by our short team in a very short period. We have here 8 to 10 major companies to represent to part this biggest event. So last to last, we have around 12 stalls and overall 12 stalls with the 10 major companies to participate in a great event. With your presence and support, we will conduct this major event called NCISRT. So thank you to all of you. Thank you.
Thank you. May I call now Dr. Radha ma'am to please come and share your thoughts on this program.
Hello everyone. So at the end of the session, I just want to share a few words. First, I would like to thank my entire team of scientific committee, starting from Mr. Pani Selvam, Mr. Mahesh, Mr. Mukesh Dan, Sasi Kumar Satti and Alisha, because it is their all together effort that we could have such a nice scientific schedule which is included starting from radiography to CT, MRI, radiotherapy, nuclear medicine, artificial intelligence, even practices of radiology. So we have had a very nice amalgamation of the topics. So thank you very much for interacting with all the invited speakers and our guest speakers to get all their topics. And also, I would like to congratulate all the delegates who has presented proffered and oral papers. We had around 70 paper and posters, so that is a very nice number. So I congratulate all of you to taking participation, active participation, because this is very important at this source that your interest in research and academics. So it is very important, particularly a round of applause I want to give to the students who came forward for this. So thank you very much. It was a very nice experience with interacting you all and seeing your enthusiasm, and definitely we look forward to have such kind of interactions in future also. Thank you.
Thank you so much, ma'am. May I call now our General Secretary, Mr. Suresh Malay, to please come and share your experience on this event.
Thank you, Nahir. I don't want to take much time. If I'm explaining my experience, it will take more time and you will shout me to go because you all are eagerly waiting to leave and flight timings or I think train timings are closing to you. Actually, the idea conceived to conduct the NCSRT 2023 in AIIMS was, I think, years before. Mr. Gokaran and Mr. Devendra demanded Central India to conduct Central India for conducting a conference in Jaipur 2019. But 2020 bid was gone to Kerala because they want some international conference. There was the Causi Quadrennial Year, that is 125th anniversary of X-ray invention. But COVID pandemic has destroyed everything. So 2021, 2020, 2021, 2022, there was no conference. 2022 we have conducted 50 IDOR or well ready day from Kerala to Kashmir. And we planned 2023 in Central India. For that purpose, I think as mentioned, as Dr. Malik sir mentioned, Daniel sir has met Malik sir in, I think, November. He proposed, instead of conducting a World Radiography Day IDOR for one day, why are you not seeking for this conference with international faculty? I would like to conduct some sort of conference like that. But I don't know why it is delayed. But fortunately, it was came for the time for a national conference. Then we met him again, I think, first week of April. I think 5th of April or something. Then he was very proud, I think, he was enthusiastic. He thought, I need the concrete idea, how many sessions, how many parallel hearts, how many speakers internationally, how many invited speakers. He was very sharp. That I remember. Then again I met him September. In between lot of negotiations and lot of discussions. Again September. I wanted he remember what I have said on 5th April. You said so. You said so. You said so. It was actually I was for me I can remember the days. And I am very poor to remember names. But he is very sharp in memory. What I have said on 5th April to him, you said so, and you said so, like that. Then I realized that NCSRT is in safe hands of Dr. Malik because he can recall everything without any use of mobile or laptop, anything. I expressed, I think I shared that experience to Dr. Radha once. That journey, I think, from April, then July, the permission, official permission, I sent the last week of April, I sent it. In the meantime, we planned to coordinate with the cardiovascular technologies. Mr. Himendra was conducting on cardiovascular update. We waited for that, but it is not materialized. Then last week of February, I prepared a very concrete idea. Mr. Shashi and Panisha sir gave me some inputs. Then he submitted to director and director agreed. And the rest is not to everyone. As usual, we have had a lot of meetings. I'm not explaining. This was my experience once. And for every aspect, even for mobilizing funds, he has promised, he has strived hard, and I think he has postponed, cancelled his trip to Bangkok for attending some conference only because of us. Our conference. Give a big applause to him. I want to tell a few words about Dr. Radha ma'am, but I am not an apt person. I am not taking much time. I congratulate and give a big salute to Dr. Malik and his team for making a wonderful conference. It's one of the best conferences we have enjoyed in this part, I think, the northern part. We had a lot of conferences, Jaipur, Lucknow, Chandigarh, but the unique conference is done by the prestigious institution. I give you a big thanks to sir. Thank you all.
Thank you so much, sir. The journey of so many months has been briefed in just 5 minutes, and then that shows how hectic and the journey has been. Now I would like to call Professor Paneet Sanham sir to share his experience on this event, and at the same time I would request sir to please announce the results of the presentations, paper presentations.
Thank you, Nagita. Respected dignitaries on the dais, Dr. Malik sir and Dr. Radha madam and the others, and of the dais, dear delegates and my dear students. Thank you very much. It was a wonderful experience. As far as the scientific committee is concerned, I would like to thank Dr. Radha madam. Under her leadership, we were working for past, at least for past 2 months, we were really working hard to make such a beautiful, because as Madam was mentioning, the number of papers was huge. At the same time, since it's a national conference, we don't want to miss it also. We want to give an opportunity to all of them. So that was decided by all of us, and finally we thought that instead of 1 hour, we'll have a parallel session also. Then only it's possible for do that. And similarly, like how Suresh said, how Dr. Malik sir was very sharp in asking the things. I think Dr. Radha madam also was really behind us in making the scientific program. So thank you, madam, for finally it has come to a new good shape and everything went on well. Thanks, madam. Thank you for that. And I'd like to thank all the scientific committee members, Mr. Sasikumar, Mr. Mukesh Jain, Dr. Dhananjay, Alisha, and I think I am not Ms. Magesh. So all of them for the wonderful contribution towards the success of this program. Okay. And finally, before telling the prize, I would like to thank all the judges, particularly for oral presentation for students as well as for the preferred papers by staff and poster presentation. So there were around 8 judges were there, 9 judges. So personally, on behalf of scientific committee, I would like to thank all of them for their sparing the time in evaluating the papers. Thank you very much. Can I request Mr. Shikumar? Let us see first about the staff oral presentation. There are 2 prizes are there. The committee and as well as the scientific committee and ISRT governing thing, we have decided that we'll have 2 prizes. The first prize will be a cash prize of ₹1,000 as well as the certificate, and second prize is a cash prize of ₹500 and the certificate. I request Dr. Malik sir and Dr. Radha madam to issue the prize to the winners. Let me tell the second prize first, then we'll go to the first prize. The second prize in staff oral presentation goes to Ms. Akila Arjunan from SRM Institute of Medical Science. Give a big round of applause, please.
Sir.
Thank you very much, sir. Usually, my HPS used to do this anchoring, but due to his having a flight, we thought we will share it. So, Paneet sir, I asked Paneet sir, you do it. but he didn't allow me. No, he also has to come. So I'm going to announce the first prize, the one by the category of staff oral presentation. Is Mr. Joy K. He's from SCT Trivandrum, Sri Chitra Criminal Institution from Trivandrum.
Thank you, sir. Congratulations, Mr. Joy. Next, we'll move on to the student e-poster presentation. There were 11 poster presentations were there. In that, we have chosen top 2. The second prize goes to Mr. Manna Devnath from Chartered University, Gujarat. Mr. Manna.
Congratulations, Manna. The student e-poster presentation, the first prize goes to Miss G. Brinda from Nitya University from Bangalore. I request Dr. Radha ma'am to hand over the prize to the winner. Now we will go move on to the student oral presentation. There were around nearly 28 papers were there, and we had 3 judges. They are also at a tough time. As I said, the third prize here is 500 rupees, and the second prize is 1000 rupees. First prize, of course, Mr. Shashi will announce later. The third prize in student oral presentation goes to Mr. Mohammad Shireen from Mallareddy University, Hyderabad. I think they left it. Anyhow, we'll try to hand over to them. Let me tell the second prize. Second prize winner for student oral presentation is once again from Nitya University, Mangalore, is Mr. Dinesh Kumar. I request Mr. Deepak to hand over. First prize for the student oral presentation is a special prize, sir. Since this prize awarded as named as Professor S. Panirselvam Best Paper and Endowment Award, it was introduced by him in the 2014 onwards. That trend is still continuing. For this, I'll announce the name of the winner. Is again Miss Niveda from Nita University from Mangalore. I request Professor Panir Salam sir, Dr. Rajesh Malik sir and Dr. Radhik madam to hand over the certificate and cash prize, the memento to the winner. I think with this I'll hand over the mic to the Nagita.
I'll take a minute. I forgot a couple of things, so I came here again. As you all know, nobody can be working all alone, so I forgot to thank few people whom I really wanted to thank from my heart. And that is my team that has worked brilliantly for the past about 1 month. I'll name all of them. My faculty, Dr. Radha, Dr. Aman, Dr. Abhinav, Dr. Ankur, Dr. Jeevan. That's them. Then my residents, Harsha, Ishudeep, Akarsh, Rahul, Ankit, Sakshi, Raj, Hemant, Monisha. If I'm missing out any, I'm sorry, but all of you, thank you so much. Then of course my team of technologists, I have Abhishek sitting here, then I have Silochana, I have Garima, I have Surabhi, I have Priyanka, I have Ankit, I have so many. You're all here in my heart and thank you so much for working day in and down for me. And of course, these naughty frontiers who are sitting in the front row who have been my students when I was in Gandhi Medical College. Iman, you all, thank you so much for being a part of us and participating and helping me in projecting your conference for yourself in the best possible way. Thank you so much.
Thank you so much.
Sir, actually, I also would like to forget one thing. I want to thank Dr. Radha Madam. One more thing is, she has allocated the PGs in various halls. Wonderfully, they have done it, and actually, to be very frank, me, Shashi, again, everybody, we were very happy, and it's easy for us because everything, loading right from loading the PPT from the preview station till it comes here. Similarly, all the parallel 3 halls. Thanks to all the dear PGs for the wonderful contribution towards this. Thank you.
Thank you so much. Now we'll move to the honoring ceremony for the people who have been the pillars for this NCISRT 2023. For this, I'll request our General Secretary, Mr. Suresh Malay, to please table the honoring ceremony.
Thank you, ma'am. I think this is the most wanted, essential, inevitable part of a conference. In our language, there is a proverb, for marriages, when marriages were conducted in the hall, not in halls. We were making firewoods because of some axes, and we were pulling the water from well. I think 20 years, even 30 years back, these persons were not in the limelight. These are the persons that will be really making the food, everything. So, or a conference, I am sitting there, Chelomar is sitting there, but we are not the persons really behind this. Under the dynamic leadership of Malik sir and ma'am, there are a lot of people who are not in the limelight. Actually, this credit goes to them only. For all of them, you please give a good task. First of all, I would like to invite a man, no one else, Dr. Rajesh Malik. The full credit goes to him only. Without his dynamic leadership and what we can say, commanding activities, we cannot take it. It would not have been achieved. I am inviting our President, Mr. Selvakumar, to hand over the memento to Malik sir. Dr. Radha S. Gupta, there is no words for her. You always need research and original papers. I told Paniswara sir, how can we make full papers as research? Because technologists like us, we don't have enough time, and most of our members are working not in academic institutes. But he was some compulsion, it's for good, to promote the research and development. I am not telling about, but she was very sharp on it and meticulously planned a scientific session. Every day, even 1 hour she has talked to me, and I don't know how many hours she has talked with others in the scientific committee. I was not in committee, but she has sought some inputs from me. Sir, ma'am, I would like to invite you to receive a memento from not from others, from Mr. Paniswaram, who was your right hand in the committee. Sir, please come. Dr. Abhinav, I think he was taking care of the stalls, trade exception, something like that. All, the audio-visual, all. Entire event is managed by him. I invite Dr. Abhinav to come on the dais. I invite our dynamic finance secretary, Mr. M.J. Joseph sir, to hand over the memento. I invite Dr. Aman Kumar, he's associate professor here. He was taking care of registration, transportation, accommodation, everything. Please come on the dais, sir. He was one of the pillars for this event. I invite Manjita Kaur ma'am from CMC Vellore to hand over the memento. He is our National Council member. I invite Dr. Angur Patel. Please come on the dais. He is the person behind the gala dinner and the food and accommodation refreshments. We all enjoyed. I invite Dr. Dhananjay Kumar to come on the dais and have a handover. He also enjoyed the gala dinner well. Dr. Dhananjay. You are so foodie, I know. invite Dr. Ankit. Ankit Brahmin. Mr. Ankit Brahmin, please come on the dais. I invite our very young member in the governing body, Dr. Daniel. Please come on the dais and hand over the memento. I invite a dynamic person, organizing secretary. Organizing secretary is a key person for everyone's the conference secretary is in the name of organizing secretary. Mr. Abhishek Sarawat. Please give a good applause. I invite Mr. Sunil Kumar, our senior vice president, to hand over the memento. Dr. Sunil Kumar, yes. Please come. I invite Mr. Himendra Sharma, co-organizing secretary. He made our welcome dinner and governing body meeting very fantastic. Not only he was a very good singer. He is trained radiography. He practiced cath lab technology. He is a radiographer from cath lab technology by profession, a singer by passion. He has made his wonderful efforts for this. I invite Mr. Mukesh Jay to come on the dais and hand over the memento. Mr. Mukesh is secretary, one of our secretaries. Mr. Deependra Vishwakarma, a gem in ISRT from Central India. Very courteous, very polite, very dynamic. I have no words for him. Only because of his initiation, we thought about conducting this sort of conference in Central India. It was in 2020. He and Mr. Gogar, he made this conference with sleepless nights. I invite Ms. Susmita Saha to come on the dais. Susmita is our newly elected Secretary for Welfare to hand over the memento. Thank you. Next is Mr. Sarvesh Joshi. Sarvesh Joshi is a right hand of Mr. Himendra, and not only Himendra, he is the right hand and left hand of the organizing committee in transportation, food and accommodation. Please come on the dais. I invite Mr. Srikumar Arthandran to hand over the memento. Srikumar is the newly elected Secretary for Operations in ISRT. invite Ms. Jyotsna to come on the dais. Ms. Jyotsna is the first member in ISRT from MP. Please come on the dais. He is the secretary of MP MP chapter of ISRT. I invite Ms. Bhuvaneshwari to come on the dais and hand over the memento. Ms. Bhuvaneshwari is the newly elected regional coordinator for Southwest India. I invite Mr. Vimal Kumar from Indore to come on the dais. He was coordinating the radiographers and students for making a good delegation from the Indore and Ujjain. Please. I invite Mr. Nagesh Kaul to come on the dais and hand over the memento. Mr. Nagesh Kaul is newly elected coordinator for Central India, North Central India. I invite Ms. Archana Maurya to come on the dais. I want to correct a statement. Ms. Archana Maurya is the first member in ISRT from Central India, especially from Bhopal. Only because of Ms. Archana Maurya, we started the ISRT MP chapter. She is a very good organizer. Please come on the dais. I invite Mr. Bilal Eder to come on the dais and hand over the memento. Mr. Bilal is our regional coordinator for Northwest Frontier, Jammu and Kashmir province. I invite Ms. Garima to come on the dais. She is very silent, very courteous, very dynamic, hardworking girl. I invite Mr. P. N. Nizamuddin to come on the dais and hand out the memento to Ms. Garima. Nizamuddin is our auditor in ISRT. I invite Mr. Harish Chavan to come on the dais. Harish is also right hand to our organizing team, especially to Mr. Divendra Vishwakarma. I invite our spokesperson, Saeed Nahida, to hand over the dais, hand over the memento to Mr. Harish. Ms. Nahida is newly elected spokesperson for ISRT. I invite Ms. Chitra Rajput to come out the dais. Chitra was also a colleague in AIIMS, I think. She was also in ISRT, Bhopal Academic Club and MP chapter. She was coordinating the delegates and students in Jabalpur area. I invite Mr. Rajiv Krishnan, Vice Chairman of ICRT, to come on the dais and hand over the memento. I invite Mr. Braj Mohan to come on the dais. He is also one of the main pillars of the organizing team. I invite Mr. Sashi Shetty, the newly elected program coordinator for ICRT, to hand over the memento. I invite Mr. Dinesh Kumar, a very silent organizer in the organizing team. I invite Ms. Priyanka Sharma. She was dealing with registration and reception in organizing team. I invite Mr. P.S. Mahesh to come on the dais and hand over the memento to Ms. Priyanka. I invite Mr. Mahesh Patel to come on the dais. Mr. Mahesh Patel is a governing body member at ISRT. He is from Ahmedabad. I invite Ms. Surabhi Bharati to come on the dais. I invite Mr. Wajid Hamid to come on the dais and hand over the memento to Ms. Surabhi Bharati. I invite Mr. Gayasuddin Teli from Srinagar to come on the dais and hand over the memento. Ms. Surabhi is very dynamic and very active in the organizing committee. He was in the reception and registration team. I invite Ms. Surojana to come on the dais. I invite Mr. Pankaj Singh, Mr. Vinod Singh, the President of ISRT UP chapter, to come on the dais and hand over the memento to Ms. Surojana. I invite Mr. Sudhish Kumar to come on the dais to receive the memento, and I invite Mr. Vinu Pariha, our Vice President of Uttarakhand Chapter and National Council member of ISRT, to hand over the memento to Mr. Sudhish. I invite Mr. Sandeep Prajapati to come on the dais to receive the memento. I invite Mr. Bajit Amit to come on the dais and hand over the memento to Mr. Sandeep. Mr. Bajit is a council member from Jammu and Kashmir. I invite Mr. Raju Pal to come on the dais and receive the memento. Mr. Raju Pal. I invite Mr. Kripal Singh Guzai, the President of ISRT Delhi chapter, to hand over the memento to Mr. Raju Pal. Mr. Kripal Singh Guzai is Chief MRI Technologist in Indian Apollo Hospital. Mr. Raju Pal is the Secretary of ISRT Academic Club in Bhopal. I invite Ms. Alisha Urkaja to come on the dais. Ms. Alisha was very active in the scientific committee. I think she is from radiotherapy. Please come on the dais. I invite Mr. Anayara Jayakumar, former president, first president of ISRT, to come on the dais and hand over the memento to Ms. Alisha. I invite Mr. Vinay Kumar Yadav to come on the dais. Mr. Vinay is from Indore and he was organizing the delegates, students and technologists from the Indore region area. I invite Mr. Bilal Ilahi from Jammu and Kashmir to come on the dais and he is our National Council member from Kashmir to hand over the memento. I invite Mr. Brijesh Sahu to come on the dais. I invite Mr. Virgin, GS Virgin, to come on the dais and hand out the memento. Mr. Virgin is our board member of ISRT. I invite Mr. Krishna Seth to come on the dais. Mrs. Krishna Seth. I invite Mr. Sahur Baba from Kashmir to hand over the memento. Mr. Sahur is our council member from Jammu and Kashmir. I invite Mr. Gaurav Prasad Chaturvedi. Vimal on behalf of Gaurav Prasad Chaturvedi. Please come on the dais, someone. I invite Mr. Madhvan Sharma from Lucknow. He is also a senior interventional radiology cath technologist in KGMU. Please come on the dais. We herewith conclude the honorary session. I think if anyone wishes Please point out.
So we are, yeah. With this, we conduct our this honorary ceremony, but there are also that we told these are the pillars of this organizing team, but there are also the sub pillars behind this success of this event. So it take few minutes to call their names. I'm very sorry if I cannot call it properly, so please apologize me for that. I would like to thank these people for helping in this event, Dr. Mukesh Sharma, and I would like to have an claps for this team in the beginning, and then I will follow calling their names. So Dr. Mukesh Sharma, Dr. Harsha Surana, Dr. Ishudeep Kaur, Dr. Sumesh, Dr. Akshara Singh, Dr. Monisa, Dr. Harshvardhan, Dr. Himant, Dr. Raj, Dr. Prashant, Dr. Sibi Rahul, Dr. Ankita Pandey. So thank you so much. So this was the dynamic team behind the success of this event. So thank you so much. We do have the announcement for the best paper presentation, so I would like to call Shashi Shetty for this. Thanks, sir. Please announce the names for the best paper presentations.
Thank you so much, sir. It was during presentation, it was mentioned that certificate will be, top 10 best papers will be distributed certificate on the stage with the instruction from the Dr. Radha ma'am. So first I'll call Miss Pavitra. I'll call on one. Pavitra, okay. Kirtika, Kirtika. They both are from Kamakshi Institute of Medical Science and Research from Chennai. I'll call Prerana Oja, SMS MC from Jaipur. Ms. Shruti Mathur, SMS MC from Jaipur. Pitlit Rakesh from Allareddy University, Hyderabad. And Kashish Francis from Christian Medical College and Hospital, Ludhiana. And Ms. Brinda G from Kesagri Medical Academy from Bangalore. Please come on stage and collect your certificate, please. I request Dr. Radha ma'am to hand over the certificates to the best top selected oral presenter. Student category. Next, I will call upon staff category who was selected for the top 10 best papers. First, Mr. Ravindra Kumar from PGI Chandigarh, Ms. Akshaya B. from Kanchipuram, Tamil Nadu, Dr. Pradeep Singh Negi, Indraprastha Apollo Hospital, New Delhi, Dr. Arnab Jyoti Dev Sharma from Assam Downtown University, Guwahati, Mr. Basil Roy, Astor Means, Kozhikode, Mr. Adityan from Pondicherry, Mr. Omkar Jadhav from PD Hinduja Hospital, Mumbai, Mr. Faisal from Malabar Cancer Center, Kerala. So next we have e-poster presenter. I request all the e-poster presenter who are there, please come on stage and collect your certificate. We'll hand out directly. Yeah. Okay, e-poster presenters who are there in on the auditorium, please come and collect the certificate from me. Thank you very much.
Just 2 minutes. So, thank you so much. With this, I will call Mr. Dhananjay Singh for a vote of thanks. Thank you all the dignitaries on the dais.
Thank you, Madam. So, for every conference or every scientific gathering, time has to come, and I am here to deliver a vote of thanks. It's a really wonderful 2 days academic fest. We enjoyed thoroughly here. It's academic fest as well as gala dinner, and hopefully you all have enjoyed. I'd like to thank on behalf of ISRT. I'd like to thank and I'd like to invite you all in NCISRT 2024 MPJ. Okay. Wish you all the very best. Happy journey. Enjoy. Hope you enjoyed, and please prepare yourself for next conference. Thank you all. Best wishes.
With this, I, Sayyid Mahidar, spokesperson of ISRT, announce the signing of NCISRT 2023. Thank you so much.